now commence with the first panel for this morning. And again, for your own benefit, interpretation, translation is available on channel 1 is in Spanish and channel 2 is in English. So feel free to make use of that. Some of the panelists will use their own language. I want to welcome all the ministers. Minister from Mexico, the Secretary of Health, Madam Mercedes Juan. Honorable Alvina Bertram Reynolds, Minister of Health of St. Lucia. The Dr. Antonio Carlos Barrios, Minister of Health of Paraguay. Dr. Yolani Batres, Minister of Health of Honduras. And of course, you have met already Dr. Fuad Khan, the Minister of Health of Trinidad and Tobago. This panel is really meant to share views with regard to the different regions. All the ministers represent specific regions in this hemisphere, and we would like to know from them basically what the situation is in their country or in the region they belong to that we get an overall picture about the situation of NCDs in the Americas. They will share with you their specific initiatives, the challenges they face, but also how they engage with other stakeholders in society. And this morning, one of the words which has been used almost by all speakers systematically, consistently, is a multi-sector approach. So I want to start with the Minister of the Secretary of Health of Mexico and ask her to talk about how Mexico, Madam Minister, is engaging with other stakeholders like the private sector, civil society organizations in dealing with this problem of NCDs. Minister Fuad Khan already mentioned some of the experiences which have been applied in Mexico. So I would like to hear from you what the situation is in Mexico, but how you engage with the whole of society approach. Madam Minister. Por favor.
Buenos días. Tengan todos ustedes. Agradecer al embajador Ramdin que nos está invitando a participar en este panel. Para México es de la mayor importancia el tema de las enfermedades no transmisibles porque nuestro país tiene una población de más de 117 millones de habitantes, de los cuales el 70% padece sobrepeso u obesidad y el 10% padece diabetes. Entonces, para el presidente de la República, el licenciado Enrique Peña Nieto, ha sido una prioridad el atender a las enfermedades no transmisibles porque, como lo decía el señor ministro de Trinidad y Tobago, el problema es que tenemos que prevenir y revertir esa tendencia que, como hemos visto, es un problema de muchos países y tenemos que aprender las lecciones de otros países que han logrado disminuirlo, como el caso de Francia, por ejemplo. Yo tuve la oportunidad de estar con la ministra de Salud, la ministra Touraine, y estamos viendo muchas acciones que ellos han desarrollado, muy especialmente a lo que se refería el ministro, de no tener o disminuir en la medida de lo posible estos alimentos procesados que contienen tanta azúcar, sal y grasas, pero creo que la importancia de esto es que hagamos ese proceso de prevención y por eso el presidente de la República en México hizo el año pasado el lanzamiento de una estrategia integral que incluye todas las acciones de educación y de promoción de la salud a la comunidad, campañas educativas, lineamientos para las escuelas, para los alimentos y las bebidas en las escuelas, pero también la atención oportuna, la atención del sobrepeso, de la diabetes, de la obesidad, para disminuir las complicaciones o las comorbilidades que se tienen, como la insuficiencia renal, los problemas de amputaciones por pie diabético, las retinopatías diabéticas que causan ceguera, los accidentes vasculares, etcétera. Entonces es muy importante esa atención oportuna, sobre todo en el primer nivel de atención, y ahí hemos hecho nosotros a través de esta estrategia integral dos cosas. Primero, fortalecer el primer nivel de atención con tecnologías innovadoras tanto para el usuario como para el prestador de los servicios. Primero con capacitación. Nuestro país tiene 32 entidades federativas, 32 estados independientes, autónomos en cuanto a los servicios de salud, pero hemos hecho redes en el primer nivel de atención con esta capacitación al personal ya en 21 estados de la República, y eso nos ha permitido tener este proceso de seguimiento de las personas con el usuario con su celular para ir viendo con esta tecnología que puedan ellos saber en qué momento les sube la glucosa o tienen el problema también de cómo van bajando de peso, y con el prestador de servicios a través de tablets que nos mantienen ahí también el control y el registro de cada una de las personas. Por otro lado, hemos hecho también un modelo de un centro de atención integral en el tercer nivel para que en nuestras instituciones de tercer nivel de investigación y de enseñanza contemos con un área específica para atender a las personas con diabetes, en donde las pueda ver en una sola mañana el oftalmólogo, el cardiólogo, la prueba de esfuerzo, todas las acciones que tienen que llevarse para prevenir las complicaciones y prevenir la discapacidad por estos problemas. Y por último, la parte regulatoria, que me parece muy importante, y fiscal. La regulatoria es que se hizo un cambio al etiquetado, poniendo en el frente de la etiqueta el porcentaje de calorías, de grasa, de azúcar y de sal, y un sello para los productos con baja densidad calórica, que el usuario sepa que puede consumir esos productos. Y por otro lado, la publicidad se prohibió, ya está en vigor en nuestro país, la publicidad se prohibió en horarios infantiles de las bebidas azucaradas y de los productos con alta densidad calórica. Y por último, algo muy importante que hemos visto, es decir, que se hizo en coordinación con nuestro Ministerio de Hacienda y con la participación de muchas instancias y el propio Congreso de nuestro país, es que en este año se aumentó el impuesto a las bebidas azucaradas. Es un peso de nosotros, que viene siendo como 10 centavos de dólar a un litro de una bebida azucarada, y a los productos de alta densidad calórica, los que nosotros les llamamos productos chatarra, se hizo 8% por 100 gramos de cada producto. Y por último, comentar que toda esta estrategia la estamos haciendo en coordinación con las organizaciones de la sociedad civil, con diferentes fundaciones, porque no es solo esto importante, es muy importante, pero también mantener ese cambio de comportamiento en nuestros jóvenes, sobre todo que es el que lleven a cabo una activación física, una actividad física. Y hay muchas organizaciones y muchas personas de la sociedad civil y organizaciones no gubernamentales que nos apoyan y que están trabajando cada uno, incluyendo la propia industria, trabajando con diferentes modelos de activación física, porque sabemos que si no cambiamos ese comportamiento, por un lado los factores de riesgo que sabemos ya cuáles son, el tabaquismo, los alimentos procesados, los cambios de tipo de alimentación que tienen los países. Entonces yo creo que es muy importante la concientización, sobre todo a nuestros niños y a nuestros jóvenes, del cambio de conciencia en cuanto a hábitos de alimentación saludable, que es muy fácil decirlo, pero muy difícil concluirlo, y activación física, los dos factores para que podamos revertir este proceso. Yo por último quisiera comentar que nos preocupa mucho que el aumento que tenemos en la esperanza de vida en México, que es de más de 74 años, se pueda revertir en nuestra próxima generación, precisamente por el problema que tenemos tan serio de obesidad y diabetes, y que lo importante es la prevención para revertir esta epidemia, que no va a ser sencillo, pero creo que estamos dando los pasos para lograrlo. Gracias.
Gracias, señora ministra. I wanted to follow up quickly on one issue, is how do you engage the private sector? And if you have structural moments of dialogue with the private sector, the large private sector, in these priority plans of the government of Mexico?
Sí, por varias cosas podemos decir que lo estamos haciendo con el sector privado. Comentaba yo con la propia industria, con las organizaciones de la sociedad civil. La industria de alimentos y bebidas está participando con nosotros. También a través de diferentes fundaciones, por ejemplo, lo que menciono yo del fortalecimiento que estamos haciendo en el primer nivel de atención con estas tecnologías. Incluso tenemos una fundación de una persona que tiene muchos recursos en nuestro país, que nos ha donado totalmente todas estas tecnologías para que las podamos llevar a cabo, porque pues sabemos que no hay recursos que alcancen para poder dar atención a toda esta gran epidemia, y la participación de la sociedad civil. Y además nosotros esto lo vamos a hacer ya seguramente en unas 2 semanas, un observatorio ciudadano. Este observatorio consiste en que a través de una serie de indicadores que hemos establecido con la academia y con las propias organizaciones de la sociedad civil, externamente este observatorio ciudadano nos va a evaluar la estrategia que estamos llevando a cabo en nuestro país, y es fundamentalmente sociedad civil y sector académico.
Muchas gracias. I want to go from a very large, relatively speaking, a large country as Mexico to a relatively small country, St. Lucia in the Caribbean, and ask you, how do you as a government deal with NCDs in general, but specifically in terms of the cost involved, the involvement of all sectors in society, and if there are specific initiatives you have taken to deal with this issue within St. Lucia or in the wider OECS countries?
Thank
Minister.
you. Thank you very much, Deputy Secretary General. I also wish to thank Minister Khan for this discussion and other partners this morning. We're very pleased to be here to share information and, of course, to be part of the action as it pertains to responding to NCDs in the Americas. St. Lucia's population, a little over 160,000 people. And out of that, the top 5 causes of death would be from non-communicable diseases. Some of these are heart disease, hypertension, diabetes, and cerebrovascular diseases. In St. Lucia, the government of St. Lucia spends over $1.4 million a year in providing medication for persons with diabetes. We have started the first phase of UHC, Universal Health Coverage, and the first phase was providing medication for all diabetics, and the second phase was diabetics and persons who are suffering with hypertension, and that is costing the government quite a bit. In fact, it is estimated that per person per year, the government of St. Lucia pays about $598 per person per year in medication for diabetics. Recognizing that, the Ministry of Health has taken drastic steps to respond to that, and of course using the multi-sectoral approach. And I really wanted to go back to what the ambassador for Trinidad and Tobago to the OAS spoke of this morning, and he used the words captain of the ship, referring to leadership, ownership, partnership, and kinship. And of course, in St. Lucia, I took leadership when assuming office in 2011, and I started with the cabinet of ministers to ban kind of sweet foods in the cabinet room, using, of course, healthy foods, fruits and vegetables, coconut water, and only, local foods, especially when it comes to diets. Even in the parliament, we would go as far as assessing what is served to ministers as well as parliamentarians. I am also a parliamentarian, and so I found this to help me out very well in that quest. We started with a health walk. Ministers were involved in a health walk through the city. At the end of the walk, took a health pledge, which they pledged to live healthy lifestyles. And I am monitoring them very closely to ensure that they do just that. Joining us on this walk was the President of the Senate, that's the upper house, the Speaker of the House, which is the lower house, the Commissioner of Police, other members from various communities and ministries. The Ministry of Health has started also a walk every Thursday. I, as minister, and my team, my chief medical officer, my permanent secretary and deputy, we walk every Thursday along the route through the city so the people from going home can see us walking through the city and along the most busiest part of the country. Engaging in following this, we have many other activities that we have engaged in, and I want to give a little highlight about what we've been involved in. We have established special non-communicable clinics at our wellness centers, during which clients can access a range of testing services, special food care services, physical activities. So persons with hypertension or diabetes come in and they actually engage in physical activity once a week. They go walking and they engage in activities. As Madam Director spoke of Caribbean Wellness, there is a big activity for us in St. Lucia. We engage in a lot of health fairs and exhibitions. We collaborate with ministries of agriculture, Ministry of Youth Development and Sport, Ministry of Education. We have gone into the schools and looking at the diet, the healthy foods that are served to children at the school feeding program. As often as possible, we know that children who come from disadvantaged families are most vulnerable when it comes to NCDs. And so they are presented with a meal at the school level, and so the Ministry of Health collaborated with the Ministry of Education and Agriculture to serve healthy foods. Very recently, we held a workshop for the cooks who are engaged at those schools, where chefs were brought in from the St. Lucia Hotel Association. This is our collaboration with other agencies to train our cooks as to how to prepare the foods where it will be palatable and look appetizing to the children so they can actually consume healthy foods, and teach them as well. We do agriculture at the school, so the children are engaged in planting on the greenhouses, engaged in planting and using the foods their own selves. We bring in the police department. We are trying to set up the teams, health teams at the different health regions. And so we engage in what you call a wellness train. We from the Caribbean, our culture is music, it's food, it's rhythm, like Minister Khan spoke to, culture and carnival. And so this is what moves people. We established that in St. Lucia. And so the first team, which is my constituency, we started with a wellness train targeting children at the school level, with a big truck, with heavy music, with banners and balloons, and a motorcade of about 20 vehicles rolled into every school. And the children were dressed in their physical education uniforms, and they were engaged in activities. There were exhibitions of healthy foods. So we engaged them at every level, even the preschools. Joining us on that motorcade, on that wellness train, was the police, at the front, riding bicycles, because they are part of the wellness team. Social workers, dentists, doctors, all teams serving, environmental health officers who spoke about chikungunya, spoke about dengue, prevention, management, all vectors in the community. So we brought all the teams serving that health region together, principals and students, all of them came together and brought the message to the schools. Following this, we asked them now we challenge them to continue the work. The police department held a soccerama where they invited all under 16-year-olds. We had 16 teams participating in a healthy activity over soccerama. The youth and sports department held a healthy little chefs competition among all the schools. So they had to use local foods to have a competition for cooking. The Ministry of Agriculture, again, trained the cooks at the schools to see how they could present healthy foods being palatable and appetizing. So we have lots of activities and programs that we have continued to roll out with the Ministry of Health and partnering with other agencies as coming from the declaration in 2007. It's a lot more work to be done. We have started, we are very aggressive, but there's so much more to be done, and we're hoping, of course, the support from the Ministry of Finance in engaging in doing much more that we intend to do.
Thank you very much, Madam Minister Reynolds. Two follow-up questions quickly. First of all, leading by example and going to the communities, working with the target audience directly through your examples given. But have you seen, as you mentioned, follow-up and continuation of an activity in terms of continuing the exercises? Have you seen any impact? Can you measure, say, what the impact is on NCDs and the level of incidents within St. Lucia?
Yes, in the short space of time, we have seen persons more involved, for example, in health walks. Many private entities may want to advertise the foods, and so they have health walks, which they invite the Ministry of Health to participate. We go as Team Health on the walks, and we see the exhibition of healthy foods. And we go around to see what is presented to the general population. It is always, I think, a good point for us when the minister, I attend almost every walk in the island just to ensure that we have a presence as a ministry, and we demonstrate whether it's be oral health, we do testing, and now as activities continue to happen in the area of sports, for example, just before I left St. Lucia, persons would write to the ministry, ask that they're having a sporting event and they would like our team health to come and set up testing for men, testing for adolescents if they're having a cricketorama. It's a day activity, so they ask the team health to come and set up testing sites for them to have, whether it's the STI and condom demonstration. So it is involving a lot more than just the Ministry of Health, but Ministry of Agriculture would come along with us to show how you can have your kitchen gardens, what you can use to plant. We are very happy about this, like I said before, but there's more to be done. And of course, when we bring it down to dollars, education is so important. Back in the day, I know you've heard an apple a day keeps the doctor away. We tried to change this around to say a banana a day because we produce bananas in St. Lucia, and of course apples are expensive. So apples and grapes will not necessarily be the thing to put in the children's lunch kit. It might be bananas, guavas, and we give them the nutritional content that they know they can support. This is what you can afford. We tell parents, this is what you can afford. If it's a banana, if it's a guava, if it's a mango or golden apple, we show them we have agro-processing plants. And we use the products from the agro-processing plants from rural women to bring into the schools. So when they make the local juices, the pulp, these are bought from the schools. Farmers are now selling directly to schools in terms of local food. So there's the change coming on. It's coming on, not fast enough for us, but at least we see the swing. And I am happy to report that there are ministers who are speaking the language of healthy lifestyle. The Minister for Agriculture, for example, the Minister for Education as it pertains to children. And this is what we want, to start with the leaders and of course the groundswell from the bottom up. We target women a lot because there are many women in St. Lucia who are head of households, single parent families. And of course we know that there's the issue of poverty. So we try to see how we can empower women to use the little that they have, to be more creative in the kitchen for the children so the children could consume what they're able to present them with for school. But definitely more health fairs, more engagement by the Ministry of Health to come support them in their various activities.
Thank you very much, Minister. I appreciate very much your passion about it, as you're very much in it. I think that's also leading by example. I must say that I'm happy to hear the focus on local foods and local produce, what is known and what is available. But regretfully in the Caribbean, whenever I come in the Caribbean, one of the first things I'm asking is for coconut water. And there are not many places where you can get them, while they grow all over. So there is a need for a policy, a broader policy, to facilitate this focus on local food. Excuse me. Ladies and gentlemen, this is one of the few panels I have seen which is so gender balanced. Because I know somebody in the audience would ask me about why, if it was only males, why not female? But I'm very happy to see 3 female ministers of health present. So thank you very much. But now we will go to the other side, to Minister Barrios from Paraguay, the Minister of Health of Paraguay. And Minister, I wanted to ask you, apart from your own presentation, which you will do through a couple of slides, to also focus on the impact of information and communication technology on NCDs. A lot of our kids are so much engaged with computer games, TV, and all kinds of other things, and they don't have that activity level as we used to have before. So if you want to include that in your presentation, appreciate that. Minister Barrios, se tiene la palabra.
Sí, muy buen día. Un saludo a todos los colegas, a la comunidad diplomática. Bueno, Paraguay es un país de 7 millones de habitantes, un territorio de casi 400.000 kilómetros cuadrados, con un perfil epidemiológico que está pasando con una doble carga, que es las enfermedades transmisibles como el dengue, la tuberculosis, chikungunya y el riesgo del ébola, al mismo tiempo el desafío de las enfermedades no transmisibles. Como todos los demás países, las cardiovasculares, la más importante, la diabetes en el 10% de la población, enfermedades respiratorias crónicas, el cáncer y, por supuesto, la obesidad. En mi país, el 57% de la población padece de sobrepeso. Tenemos los lactantes menores de 1 año también ya con sobrepeso, por eso se ha vuelto a impulsar la lactancia materna a través de un proyecto del Ministerio de Salud en el año 2013 de creación de los lactarios, y estamos tratando de las fórmulas ver una forma de limitarle su comercialización. Tenemos los niños menores de 7 años con un 7% de obesidad y tenemos a los adultos con más de 35% de sobrepeso. Tenemos el mismo perfil de toda la región, con números más, números menos, pero es el problema con la obesidad. Con respecto a las estrategias que estamos llevando a cabo en nuestro país, por este doble problema epidemiológico, primero es controlar los factores a través de las intervenciones con bases poblacionales y mejorar la asistencia médica en lo que se refiere a la asistencia primaria de la salud, equipando los equipos de salud y capacitando a las personas, al equipo médico. También en ese sentido tenemos una población tremendamente grande, está distribuida en 18 regiones sanitarias, estamos reorganizando nuestros sistemas, dándole una importancia mucho mayor a las enfermedades no transmisibles. Tenemos un programa cardiovascular, un programa de diabetes, un programa de cáncer, un programa de tabaco. Estamos haciendo un organigrama nuevo donde formamos una dirección de enfermedades no transmisibles. También tenemos un plan de acción para este año que hacemos el lanzamiento el 23 de octubre justamente del 2014, que va a durar este plan de acción o tiene un espacio de aproximadamente 10 años. Queremos hacerlo 2014-2024, donde vamos a tener los siguientes ejes. Ejes de prevención de enfermedades crónicas no transmisibles, respuesta al sistema de salud frente a las enfermedades no transmisibles, una vigilancia epidemiológica y las metas con indicadores. Y el Plan Nacional de Acción para la Prevención y Control de las Enfermedades no transmisibles incluyen 4 estrategias para 4 enfermedades: la cardiovascular, el cáncer, la diabetes, las enfermedades crónicas y 5 factores de riesgo: la obesidad, la alimentación no saludable, la inactividad física, el tabaquismo y el alcohol. Con respecto a la alimentación no saludable, tenemos una ley de obesidad dictada el año pasado, 2013, donde habla de la implementación o de la obligación de alimentación saludable en las escuelas, donde también existe una interacción con otros ministerios, como por ejemplo el Ministerio de Agricultura, con la formación de huertas en los colegios de las regiones del campo, con la obligación de la implementación de dietas saludables en los colegios y en las universidades, también con el plan del desayuno escolar y el almuerzo escolar ya hecho de una manera diferente y preparado a base de verduras. Dentro de los factores que predisponen en mi población a altos riesgos de enfermedades cardiovasculares, la obesidad y la diabetes, está el bajo consumo de verduras y frutas. El 84% de la población consume muy poca cantidad de frutas. Tenemos una inactividad física en casi el 70% de la población. Tenemos un consumo de tabaco del 15%, pero sí tenemos un consumo muy elevado de las bebidas alcohólicas. Casi el 51% de la población bebe en exceso. El plan de acción ha sido declarado de interés ministerial y las metas para 10 años. Nosotros pensamos de que tomando la iniciativa con respecto a la alimentación en los colegios, en las escuelas, vamos a empezar a reeducar a nuestra población en base a una alimentación saludable y estamos en el plan de los ejercicios en los colegios de establecer que exista 1 hora por día durante los 5 días de la semana de edad escolar, a ver si de esa forma estimulamos. Con respecto a lo que usted dice, con respecto a los videojuegos, en mi país la electrónica es de muy fácil acceso, los videojuegos están diseminados en todos los hogares, hasta en los hogares más carentes de recursos están en los teléfonos celulares, porque casi el 90% de la población tiene teléfono celular y la inactividad física es el patrón, ¿verdad? Entonces, eso nos conlleva a tener un riesgo importante de obesidad. La tasa de diabetes es prácticamente la misma que en todos los países, 9,7%. La tasa de enfermedades cardiovasculares, de muertes prematuras por enfermedades cardiovasculares, está alrededor de los 44%. Pensamos que con este nuevo impulso y con la nueva ley, esto podría tener un cambio. Estamos trabajando con la sociedad civil, con las ONG, para tratar de implementar programas de educación y de concienciación en forma continua. No podemos todavía tener la suerte de tener limitaciones en lo que se refiere a las propagandas sobre alimentos o bebidas azucaradas en los canales de televisión, periódicos y cualquier otro medio de comunicación. Estamos en ese proceso. Sí, ya hemos implementado la reducción de la sal en los restaurantes, ya existe la posibilidad de que no exista la sal en los restaurantes. Bueno, el esfuerzo que se hace es extraordinario porque en mi país la base alimentaria es hipercalórica. La comida típica paraguaya es hipercalórica y traducida a nuestra actualidad con la baja participación en ejercicio físico, eso es una bomba de tiempo.
Thank you very much, Mr. Minister. I think the overview you have given is pretty comprehensive in terms of the different tracks you're working on, and I thank you very much for responding to the question on technology and the impact it has on especially our young population. I want to go to our Minister of Health of Honduras, Dr. Yolani Batres, for her presentation and to share with us the activities which have been undertaken in Honduras and the situation on NCDs in Honduras and in the Central American region as much as possible. Ministra.
Gracias. Buenos días a todos y a todas. Tenemos un presidente relativamente...
Is somebody coming to help you?
No sé. Bueno, buen día, perdón, disculpas. Bueno, en Honduras pues tenemos un presidente relativamente nuevo, tenemos 8 meses de tener un nuevo gobierno, un presidente pues bastante joven, bastante reformador. Y en los últimos días pues el presidente Juan Orlando Hernández ha enviado al Congreso una nueva ley, una nueva ley de protección social. En esta nueva ley pues aspiramos realmente a lo que hablábamos el día de ayer en la Organización Panamericana de la Salud, a una cobertura universal con acceso universal. El sistema de salud de Honduras actualmente es un sistema segmentado, es un sistema separado, ¿verdad? Y con esto, pues con esta nueva ley de protección social, nosotros aspiramos realmente a fortalecer ese rol rector, regulador y conductor que debe tener la Secretaría de Salud de Honduras. Después de esta nueva ley de la protección social, el presidente Juan Orlando Hernández ha estado teniendo diferentes diálogos con la sociedad, donde comparte con ellos toda la ley y cualquier elemento que la población piense, ¿verdad?, que deba ser incluido, pues estamos a tiempo, ya que se está realmente analizando actualmente en la Cámara Legislativa. Además de eso, una vez aprobada la Ley de Protección Social, pues vamos a la Ley de Seguridad Social y a la Ley de Salud Pública. En el tema de las enfermedades no transmisibles en Honduras, pues la verdad que es bastante parecido lo que escucho aquí a los colegas hablar. En Honduras pues hay un poco más de 8 millones de hondureños. De estos 8 millones de hondureños, el 10% padece de alguna enfermedad no transmisible, ya sea como diabetes, hipertensión, entre otras, y las enfermedades cardíacas. Pero una de las cosas que más en Honduras nos está ahogando realmente es el tema, realmente las consecuencias de estas enfermedades, las consecuencias de la diabetes mellitus, por ejemplo, las enfermedades renales, ¿verdad? Este es un tema que realmente llega a impactar en la calidad de vida de la persona, pero también en el impacto económico que tiene ya en la parte financiera o en la parte presupuestaria nuestra. En Honduras tenemos, de esos 8 millones de hondureños, tenemos más de 3.000 personas que viven con una insuficiencia renal crónica y que reciben realmente no un tratamiento, porque no lo cura, es la diálisis que todos conocemos. Y realmente, a pesar de que se ha emitido o ya se cambió la ley en cuanto a los trasplantes, este no es un tema que tenemos que caminar más y avanzar más, ya que la única opción que le estamos dando a nuestros pacientes pues es la diálisis, y un tema que realmente nos ahoga económicamente. Esto, en el tema de la diálisis, el 33% de nuestro presupuesto nacional, de nuestro presupuesto para medicamentos, va para tratar diálisis. Pero Honduras ha hecho otras cosas, ¿verdad? Estamos haciendo nuevas cosas. Actualmente la Secretaría de Salud está pasando por una reestructuración, por una reingeniería, donde estamos aplicando un nuevo desarrollo organizacional. Y este nuevo desarrollo organizacional va realmente enlazado a lo que es el nuevo modelo de salud. Y en este nuevo modelo de salud, la Secretaría de Salud pretende salir de sus 4 paredes y ir realmente a la casa, ir a la familia y trabajar conjuntamente con las familias en lo que es la salud preventiva, en lo que es la promoción de la salud. En Honduras ya tenemos más de 10 años de estar trabajando con la modalidad de la gestión descentralizada. Nosotros descentralizamos lo que es la gestión y la administración a municipios, alcaldes, a ONGs, a mancomunidades. Las mancomunidades son varios municipios que se conforman y se unen. Y aquí nosotros descentralizamos la salud, pero descentralizamos más lo que es la promoción y la prevención. y sobre todo invertimos en esos gobiernos locales, en formarlos en salud, ¿verdad? Así que cuando sale este alcalde, que un periodo de un alcalde de Honduras es de 4 años, nosotros tenemos un vocero más de la salud. Aunque ellos a lo mejor no son profesionales de la salud, a lo mejor son maestros, a lo mejor son abogados, a lo mejor no tienen un grado académico superior, pero sí en estos 4 años salen hablando y son expertos de la prevención y la promoción de la salud. Cuando hablan de obesidad, Honduras pues realmente estamos pasando por las 2 etapas, ¿verdad? Tenemos el problema de la desnutrición y el problema de la obesidad. El problema de la obesidad sobre todo en la parte urbana, pero el problema de la desnutrición en la parte urbana marginal y en la parte rural. En este tema, el presidente Juan Orlando quiere impulsarlo unificadamente, que la desnutrición o la obesidad no es un problema solo de salud, es un problema realmente donde tenemos que estar involucrados todos. Conjuntamente con la Secretaría de Agricultura, con la Secretaría de Economía y con las agencias, estamos realmente dándole un abordaje integral. En Honduras tenemos una estrategia, ¿verdad?, que se hizo en Honduras, que es la estrategia de AINC, que es la estrategia de atención integral del niño en la comunidad. Antes nosotros trabajábamos solo con voluntarios de salud y trabajábamos educándoles de cómo deben ellos educar o cómo deben realmente educar a las madres vecinas, de cómo deben nutrir a sus niños, ¿verdad? Cómo deben alimentarlos. Y una de las primeras cosas es la lactancia materna exclusiva por 6 meses. A los 6 meses deben de introducir otro tipo de alimentos, pero no le dábamos la opción a la madre, no le dábamos la opción de dónde ir a buscar la papa, de dónde ir a buscar la zanahoria. Ahora, como esta es una estrategia integrada con la Secretaría de Economía, con la Secretaría de Agricultura, les enseñamos a las madres, a los padres, de cómo cultivar, de cómo hacer sus huertos familiares o cómo hacer huertos comunitarios. Y aquí pues tenemos un gran apoyo de la AID, ¿verdad? La AID, conjuntamente con la AID, lo estamos haciendo en campo. Y eso lo llevamos hasta los 2 años. Pero después, como estos niños salen de la casa, van a preescolar, van a la escuela, entonces ya vamos a la merienda escolar. Y aquí continuamos, ¿verdad?, haciendo huertos escolares, donde implementamos realmente que sean meriendas saludables. Porque déjenme decirlo que habían niños que ya preferían una soda a comerse una zanahoria, a comerse una fruta. Entonces ahora en las escuelas también continuamos para que esto no sea descontinuado, no termine a los 2 años. Además, en esta estrategia de AINC le estamos dando ideas a la madre, ¿verdad?, con lo que tiene en casa, con lo que cultivan ellos, cómo mejorar la nutrición. En Honduras, pues es una población donde comemos mucha tortilla de maíz. Entonces ahora estamos fortificando, estamos mejorando la tortilla. Y la tortilla ahora pues se le indica a la madre que le puede agregar zanahoria deshecha, que le puede agregar otras cosas donde la tortilla pues es más nutritiva. Además, le reitero, con esta nueva modalidad de gestión descentralizada, como estamos siguiendo a las casas, estamos educando a la población, la estamos acompañando día a día. Y hay en algunos municipios donde ya han disminuido tanto las enfermedades prevenibles que hay centros de salud que ya se encuentran vacíos, porque ya la gente está aprendiendo realmente a prevenir la enfermedad. El presidente Juan Orlando Hernández recientemente también ha lanzado lo que son las recreovías. En Honduras, por el tema de la inseguridad, la mayor parte de la gente ya no estaba saliendo de sus casas. Nos quedábamos en la casa pues viendo televisión, haciendo otras cosas pues que no son productivas para nosotros o que no son realmente saludables. Con el tema de las recreovías, el presidente está invitando a la población a que salga de sus casas, a tener diversión, a ejercitarse, a educarse, a formarse. Y una vez por semana, cada Secretaría de Salud, cada Secretaría de Estado tiene asignada una recreovía. Una recreovía puede ser en una zona marginada, en un municipio bonito, en un parque central, donde invitamos a la población, la instruimos a hacer ejercicios. Se dan clases de zumba, se dan clases de punta, que es el baile típico hondureño, se hacen ejercicios con la comunidad y el presidente Juan Orlando Hernández invita a toda la población a que por lo menos un día, todos los días, haga ejercicio 30 minutos al día. Así que esta es una batalla que no la llevamos sola, que estamos siendo acompañadas con el presidente y la primera dama.
Thank you very much, Madam Minister. And I think one of the key messages you have given is the importance of political leadership at all levels. And I'm very much interested in the aspect of local governments and local community leaders being trained to provide that kind of environment for a better and healthier lifestyle and in terms of nutrition, but also the different cooking techniques to involve that in the process of the traditions which are out there in society. So it's a matter of mixing culture, innovative policies with political leadership, which can bring that new environment for better and healthier lifestyle. I want to go to our last panelist, Minister Fuad Khan from Trinidad and Tobago. Minister, we have heard several examples and some go into the budgetary issues. I have not asked the Minister of Health of Mexico about how do you balance the, if you wish, the political fallout of a tax increase, which is often not welcomed. But would you want to care to reflect on some of the experiences in other parts of this hemisphere, but also to look at how do we garner a better budget in collaboration with the private sector in tackling through innovative ways NCDs in the Americas. Mr. Khan.
Thank you, Ambassador Ramdin. Well, I've listened to all the speakers, and we seem to be on the way forward, reading on from the same page. It was wonderful to hear Mexico, Minister Juan, speaking about the legislative aspect of it. And I think that is a part that we need to move forward in our country. And also Minister Reynolds from St. Lucia, who spoke a lot about the development of a culture of eating as well as movement. And as we went forward, with the Minister Barrios from Paraguay, he developed also on the plan, and also the Minister from Honduras. Although it's an early time for them, the problem has been sunk in to the extent that things have to happen. And in Trinidad, what we have done, we've developed a link with the private sector, which is we have called the Partners Forum. It's a cabinet-appointed committee where private sector as well as public sector meet and determine exactly the way forward for our NCD and healthy lifestyle movement. We have recently spoken about stamping and branding items of food items and the caloric content, as well as what is being developed externally to make people aware of the caloric content of certain food items, or sometimes dissuade somebody from eating something of a major nature, local, as I say, I don't use the word junk, but high sugar, empty calorie nature. Sometimes people may want, their taste have to be changed, the cultural taste has to be changed. And from what I'm listening here this morning, I think this is the barometer is changing, looking at the cultural taste of what is going to go forward. And I think that is a positive as we move forward. So what started off as the Summit of the Americas in Trinidad and Tobago, of the awareness of the NCDs and the NCD epidemic, I think is now shifting to a point where we all are going to be singing from the same page and moving forward. And we do hope that we could emulate that of France. And I've heard France, again, mentioned as a result of the methods of approach that they have used to maintain the population and the healthiness of the population.
Minister Khan, I think the conclusion you draw that we seem all to sing from the same music sheet, that's quite correct, I believe, because we hear all good things in terms of the legislative agenda, the political leadership necessary, the multi-sector approach, the innovative ways, the technology, working with the target audience, with the young people, and in very creative ways as well. I think indeed we have awareness at a level where it should be, but we should not be complacent. It should continue. But I think we have moved into real action as well. And that action part requires not only the legislative framework, it requires funding, but it requires ownership of all involved in this process. And I think if we can commit as a collectivity of governments, private sector, civil society at large, to focus on action and subsequently, and not subsequently, but at the same time, provide the affordable access to all, especially those in vulnerable neighborhoods, as mentioned earlier, the urban area, but also in the rural area, the deficiencies which exist. I think then we are moving further on this track. A lot needs to be done, a lot more need to be done, but I think having this positive approach towards the future and not only having to deal with the negative aspects of it, but looking at good examples, I think is a very positive outcome of this debate. And I wanted to stop here because I know that we are running over time in terms of encroaching on the time of the other panelists. So I wanted to thank you all, the Minister of Honduras, the Minister of Paraguay, Minister of St. Lucia, Minister Khan from Trinidad and Tobago, and Minister Secretary of Health from Mexico, with a round of applause for their vision and their commitment. And I know I have not allowed for a conversation with the audience, but that will come in the subsequent panels, and feel free to engage with the ministers informally when they step down. I thank you all very much, and the next panel is on.
Ladies and gentlemen, may I ask you to take your seats, please, as the panelists get ready to start the subsequent panel. Thank you. Ladies and gentlemen, may I ask you to take your seats, please? We're about to start the second panel. Thank you. For staying on for the morning's proceedings, we have had a wonderful private breakfast this morning, a good feature address, and a very lively set of comments from several countries across the hemisphere. This second panel would be a focus on the Caribbean situation and experience. And we have a very, very distinguished panel of experts seated here today. But for the Caribbean, if I may suggest to you, and it was said this morning, it's a great economic cost for us in the region, particularly the Caribbean, as regards NCDs specifically. The Caribbean has had one of the highest prevalence rates of NCDs in the Americas. For example, diabetes mortality in Trinidad and Tobago and St. Vincent and the Grenadines is well over 600% higher than that of North America. Our risk factors are also there. You would know that a great percentage of the population are of Afro descent with a genetic predisposition to hypertension, high sodium intake, and generally speaking, we have a fair amount of alcohol consumption, a fairly high intake of fats and sugars, and the question of overall level of physical activity can also be discussed in terms of what we need to do to improve. If we look at the economic burden of NCDs for the Caribbean, you would understand that Bahamas, for example, it's 1.4% of their GDP. Barbados, it's about 1.3% of their GDP. Jamaica, 5.8% of their GDP. Barbados, 5.3, I'm sorry. And Trinidad and Tobago, as stated this morning by the Honorable Minister, is 8% of our GDP. There's a heavy economic cost to the prevalence of NCDs. You heard this morning from Ambassador Ramdin. The World Economic Forum estimates it's a $47 trillion cost over the next 2 decades. And estimates are to intervene will cost global society about $147 billion. And by economic calculations, for every $1 US invested in the intervention for NCDs, the expected return is $3 US. So there is hope, and there's economic sense behind the modeling. And I think we all heard this morning about the inter-sectoral, multi-sectoral approach that is needed. It's a required triangulation between business, private sector, government, and civil society. So without intervening much further, I will introduce to you the first speaker, and please excuse him because he needs to leave as soon as he's finished speaking. So I will introduce him first. The first panelist will be Dr. Wayne Frederick. Dr. Frederick is the 17th president of Howard University. He's one of my fellow countrymen from Trinidad and Tobago. He's a triple alumnus of Howard. He's a physician, research fellow, and distinguished surgeon. He was previously associate director of the Cancer Center at the University of Connecticut. He's the author of numerous peer-reviewed articles, books, chapters, abstracts, and editorials, and he continues to lend great support and innovative solutions to furthering the mission at Howard University. Dr. Frederick will be speaking on the aspects of the educational and institutional strengthening required to deal with NCDs. Following Dr. Frederick, if you don't mind, Dr. Frederick, let me introduce the entire panel and then we can take them individually. Sure. Following Dr. Frederick, to my immediate right is Dr. James Hospitalis. Dr. Hospitalis is the Executive Director of the Caribbean Public Health Agency, CAFRA, and he has also played a key role in increasing priority and resources for NCDs, including helping organize the CARICOM and UN summits on NCDs. He has also been a director of the Caribbean Epidemiology Center. Dr. Hospitalis graduated with honors from the University of the West Indies. He has a Master of Science degree in Community Medicine, and he's a fellow of the UK Faculty of Public Health. Dr. Hospitalis' area of focus will be multi-sectoral policy, legislation, and local accounting. Following Dr. Hospitalis, the female on the panel, Ms. Ariella Rajani. She's a senior advocate and senior advocacy manager for the NCD Alliance. She's based in New York, and she works to unite civil society efforts in non-communicable diseases. She has also led communications and advocacy for the Global Alliance for Women's Health. She's a graduate of New York University. Mrs. Rajani's contribution would be focusing on the regional perspectives and with a focus on the post-2015 development agenda. Following Ms. Rajani, we will hear a presentation from Mr. James Hogan, Vice President and President of Medtronics Latin America. In a very tight nutshell, Mr. Hogan is a serial entrepreneur and has held senior executive roles in several medical device companies and biotechnology companies, but currently sits as the president of Medtronics Latin America. He has worked and lived in England, Switzerland, France, Israel, Holland, with a very diverse international background in terms of his experience. And Mr. Hogan's focus would be the industrial sector perspective with private sector public engagement as a focus in terms of partnership. And last but by no means least, we will hear from Sir George Alleyne. Sir George is a doctor by training, very well accoladed in the area of medicine. He was the former United Nations Secretary General's Special Envoy for HIV/AIDS in the Caribbean region. He's Chancellor of the University of the West Indies. He's Professor Emeritus at the University of the West Indies. He's also a past Director of PAHO and presently Director Emeritus of PAHO. And he has served as member and chair of PAHO's Advisory Committee on Medical Research. I promised him I will not read his CV. It's very extensive. Having said that, ladies and gentlemen, it was with great pleasure and humility I pass the floor to Dr. Wayne Fredericks, who will take us through a conversation. Each one of you would have approximately 8 minutes to contribute, and then we will open the floor to some questions. Dr. Frederick.
All right. First, let me thank you, the Honorable Ambassador, for having me here today. A major part of what Howard University is about speaks to this. The diaspora is one that we've been committed to since our inception. And we've had students from the Caribbean as early as the late 1890s. And that has been a major part of what we've continued to do. It's certainly a pleasure to sit here with the rest of the distinguished panelists, and I appreciate you giving me the opportunity to speak and then leave because of some commitments that I have. I also have to acknowledge the dean of my medical school who's here, Dr. Mark Johnson, as well as I see several Howard students here as well from my medical school, which is all part of what we try to do outside of the classroom as well. We currently have about 452 medical students, and if you look at our breakdown of our medical school, about 10% of them come from foreign countries directly. Several of them are second generation as well, but primarily coming directly from the Caribbean and Africa in particular. We have about 10%. Our medical school breakdown in terms of what we are supporting and the areas of interest, certainly primary care is one area that we are highly focused on. And I mention that because I think prevention, as you talk about non-communicable diseases, prevention is a major part of what we must promote. We currently have an international rotation in Haiti as an experience that our students can take, not just our medical students, but our dental students, our nursing and allied health students, and our pharmacy students. They usually go at the end of June into July. It's a 4 to 6 week rotation. And the experience, again, is meant to take them out of the comfort zone that they usually will learn their medicine in here in the US and put them into the different areas that we would like them to eventually practice in. And so far, it has been a very rich experience. That experience to Haiti has really given them a different dimension. They don't have all the bells and whistles that they would usually have in the circumstance, obviously, here in DC. But I think it gives them an opportunity to practice the medicine that we would like them to learn ultimately. Wrapped in that, we have a lot of research activity occurring in the African diaspora, which we would like to spread into the Caribbean. That research activity primarily is around communicable diseases, but the more time that we've spent there, we are seeing more opportunity to participate in non-communicable diseases. We are really pushing into professional education as well, where the patient is the center of our focus, and I tell the medical students that repeatedly, that the object of our affection is the patient, and we have to build systems that surround and envelope the patient in a type of comprehensive care system that really can be built anywhere. It's not a technology issue, it's how you build systems around treating patients. And I'll give you one example. In Zambia, where we have a research project looking at HIV, we have trained pharmacists in the community to interact with the patients in their private pharmacies. So when the patients come in, the pharmacists have the patient's labs, and they can prescribe prophylaxis right there and then. That type of interaction is what we're looking for. Here in DC, we have a system whereby patients in our diabetes treatment center can have their finger sticks done on the weekend and have them downloaded wirelessly back to our physicians. So if a patient on a Saturday after celebrating a birthday has had too much cake and has very high blood sugar, that patient is not going to wait until Monday for an intervention. We have a physician who can call that patient immediately and do that. So one of the things that I think will be helpful in non-communicable disease management is certainly leveraging technology to bring prevention and to bring intervention more quickly to patients. And I think a lot of the companies now are looking at that as well in terms of how can we leverage technology to really have a supportive system to do that, and to do that effectively and quickly. Now, my background obviously is as a cancer surgeon. I mainly operate in patients with GI cancers, and I have operated in the Caribbean. That experience is one that has really opened my eyes about what is available on the treatment side, but how much more can be done on the prevention side. The patients I operated on in the Caribbean, all of them had fairly advanced GI cancers, GI malignancies. And that opportunity to intervene is one that obviously for the cancers I operate on, such as pancreatic cancer, colon cancers, you want to have early detection. Obviously, we want to prevent, we want to stop smoking, et cetera. But when patients do develop these diseases, we certainly want to have an early intervention. And that screening part of what is being done is something that we can certainly add to. Now, speaking of leveraging technology and looking at screening, we just built a surgical simulation center at the university, a multi-million-dollar project. And one of the advantages of this is that it really can promote these types of endeavors from a training point of view. So we have mannequins where you can simulate certain types of operations, but just as importantly, we have simulated endoscopies as an example, where you can bring people's skill set up very rapidly in a non-threatening environment where you can really promote endoscopic training and the likes. And so one of the things that again, from a health sciences perspective that we're promoting is that early intervention. So if we can detect these cancers earlier, we'll do that. I operated on a gentleman just this past Sunday and for pancreatic cancer, and unfortunately he had metastatic disease already, presented with obstructive jaundice, too advanced for an intervention. And actually, next week, October 5th, we'll celebrate. I have the first patient I operated on independently at University of Connecticut for pancreatic cancer. Will celebrate his 10th anniversary of survival. Early detection he had, and he was able to have a Whipple procedure, pancreatic duodenectomy, and he'll celebrate his 10th anniversary surviving. So that early intervention clearly in this disease process is helpful. So again, I'd like to thank you. I'll stop here and I'll take any questions.
Thank you very much. Dr. Dallas, the floor is yours.
Thank you, Ambassador, and good morning to everyone. Well, you've asked me to focus some on multisectorality and legislative and policy issues. And the first question I want to ask of the audience is there anybody here from public health? Any doctors in the audience? Any doctors in the audience? There's only one doctor in the house, 2, 3. Anybody from trade? Anybody from education sector? Anybody from agriculture? Any legislators in the house? Anybody from urban planning or transport? See, we have a problem. I'm sorry. I see a lot of the folks I know quite well. If we're going to talk about multisectorality and so in going forward from this, we have to engage legislators, urban planners, we have to engage agriculture, education, finance, as much as we engage with public health and medical people. We care about it, but somehow we have not been as good at reaching across to the other sectors to engage them in seeing how what it is they're struggling with and how what we do can actually contribute to their delivering on what it is they're struggling with. But I have the privilege of being the director at CARFA and the previous head of NCDs in the Pan American Health Organization. The word multisectoral is mentioned 15 times in the UNHLM document. So 3 years after that, we're in a meeting here today and we still don't have a multi-sector audience. We're still somehow not getting there. And I think the OAS is a great place for that framing and the CARICOM community because you do have education ministers who meet, agriculture ministers who meet, labor ministers who meet, and so on and so forth. For us in the Caribbean, the tourism sector is a huge sector, the biggest employer. And so a good chance for getting health promotion policies in there. We know we have a huge problem. We know it's not sustainable, the costs. So we know it takes this, all of society and all of government action. But how to actually raise awareness with the others, how to increase that connection to them and to get the action that's needed. At CARFA, we do the traditional things. We collect the data on mortality and on trends. We work with PAHO on the risk factor surveys. And more, we are looking at more critical analysis of the social determinants of the NCDs in terms of poverty and access, because those drive it. And we do prevention. We do support clinical care by providing guidelines adapted to the Caribbean on diabetes, hypertension, asthma. You know something? Evaluations show the doctors don't use those guidelines very much. They ask us to make pocket guidelines. We make pocket guidelines. They still don't use it very much. So a real challenge in terms of social marketing and communication is how do you get providers to actually use the evidence-informed guidelines? I think in part we need patient guidelines. So the patient goes to the doctor and says, here's what I think I need you to tell me. And so the civil society component in terms of empowering people is really important. The other thing that we do at CARFA is, and more so recently as a new public health agency and as part of the CARICOM system, is pushing for the multisectoral linkages. So we report to the we report to the Council of Human and Social Development, but late last year I reached across with colleagues from CARICOM to the trade and economic development sector, and I attended a meeting of trade ministers and said, you know, we have obesogenic environments. Most of the food in the Caribbean is imported. So the way to adjust diet is perhaps to work with trade policy and look at instruments like intellectual property, market access, technical barriers, look at things like phytosanitary and sanitary. And they listened and they said, you know, nobody from health ever came to talk to us before. This is interesting what you're saying. And now we've just commenced a piece of work to prepare a joint meeting of the trade and health ministers, really going into detail on how can we adjust trade policy to have less obesogenic environments in the Caribbean, because we're really suffering from it. I went back to Trinidad and Tobago last year. I was saying to my colleague Silvana Luciani, it is scandalous what's happening. The bombardment of advertising to children with blatant manipulation. They're not rational economic decision makers to choose foods high in salt, fat, and sugar. The amount of the pressure and the expansion of chains that are supplying not traditional, more healthy cuisine, but a lot of unhealthy stuff. So I think that whole area is important for multi-sectoral action, and working with trade, working with agriculture. The other thing that we've realized in looking at the Port of Spain Declaration, that's another thing CARFA does with CARICOM, is to monitor the progress with the achieving the indicators in the Port of Spain Declaration. Some people may know that was set out by CARICOM heads of government in 2007. And for the last 7 years, 20 countries have been tracking 20 indicators. Some of commitment, some of diet, some of physical activity, treatment, and so on. And in the area of diet and nutrition, just about no country can record any progress. I mean, there's no mandatory labeling of processed food produced in the Caribbean for Caribbean populations, which is not a health issue. That's a standards issue. That's a consumers affairs issue. That's an attorney general issue. I mean, there's no mandatory elimination of trans fats from the food supply. That's a food manufacturing issue. That's a Trinidad and Tobago manufacturers and a Grace Kennedy in Jamaica issue. I mean, there is no effective mandatory physical activity in the schools. That's what the declaration called for, but a principal could say, well, yep, we have mandatory physical activity. It's once a month for half an hour. Being ridiculous, but we needed actually to be more, in terms of getting action, we needed to be more precise, 150 minutes a week, or whatever the formulation would be that is informed by evidence. And so we have realized that one of the greatest stumbling blocks to giving expression to the political will of the Port of Spain Declaration is a lack of legislative capacity. And this is holding for other things. You talk to countries about violence and injury prevention, and the breathalyzer law is stuck for 2 years, or the new law on age limits for drinking is stuck for 2 or 3 years. You talk to the public, the need to update the international health regulations, and all the public health acts, or many of them are dated. So we have recently signed an agreement with the International Development Law Organization to really focus on stimulating the legislative capacity needed to give expression to the political will that our leaders have so, in a visionary way, put forward. PAHO has coming up this afternoon a very important resolution on health-related legislation. And I've been urging the Caribbean countries to support that, because that's going to be one of the ways that we're able to achieve the multi-sectoral policies that are needed. If you look at something like physical activity, again, we need changes in urban planning and transportation that have not been happening. In Trinidad, I've just relocated there. A large road development into a major community called Diego Martin. No bike lanes, no walking paths, no provision for pedestrians, not even thought of it. And yet the cost of doing that would have been a marginal extra cost of what must be tens of millions of dollars of expenditure. In St. Kitts and Nevis, I saw one of those recently, new road development. I don't know if the IDB is here, but I think they funded it. No provision for sidewalks, no provision for bike lanes. When you put fast roads into a community and no sidewalks, you actually disrupt community life and community activity. You make the roads less safe. You make people less likely to want to walk. Turn it around, you put sidewalks, and people can actually hang out on the sidewalk and talk to their neighbor. They can walk to school or to work. They have a safer place because cars are less likely to run off and hit them. So we really need that awareness to be raised with the other sectors. And again, I come back to the OAS because that's where we are. I urge Assistant Secretary General that the meetings of the other sectors that are being convened, education, labor, agriculture, to get this issue on the agenda, not from the health point of view, but how can we mitigate or remove some of the preventable impediments to economic growth through attention to the NCDs. If, as Neil says, it's such a high percentage impact on the GDP, how can we improve educational outcomes by reducing some of the obesogenic environments we have in the schools? So notice my framing. I'm not saying NCD first. Improve educational outcomes, mitigate, deal with some of the preventable impediments to economic growth, mitigate climate change by improving alternative transport like biking and walking and rapid mass transport. Put the other sector first in the engagement with them. That's how we're going to get access to some of those other sectors. We need to reframe the argument, not NCDs first, the other person's interest first. And that's well grounded in scholarship about negotiation. If you look at things like getting to yes and getting past no, Roger Fisher's group at Harvard, or if you go way back into the Old Testament, you will find that the Bible says in Philippians 4:6, seek not only your own interest, but look at the interest of the other person as well. So in framing the argument and negotiating, we need to be thinking like that. I'd like to finish up with the issue of care and treatment and how multisectorality can play a role. Trinidad and Tobago, Jamaica are among the countries that have very progressive policies that make free access for medications for NCD drugs. Trinidad and Tobago has a program called CDAP with over 300 and something odd thousand people on it for hypertension, diabetes, cholesterol, asthma, and so on. A recent evaluation by CDC and PAHO showed that actually premature mortality has been declining and fairly fast, one of the highest declines in the hemisphere. That over a 5-year period, about 5,000 fewer lives were lost, mostly men more than women, and that this was largely attributable to the scale-up in treatment. The effect was accelerating and could be expected to further accelerate as other primary prevention measures come to bear, like tobacco, like salt, and so on. In Jamaica, with the CDAP program, they have 500,000 people on it. But interestingly, when you talk to the people on CDAP, on the National Health Fund in Jamaica, only about half the folks who are eligible actually access their medications, even though it's free. So the question is why? Well, there are cultural barriers. In Trinidad and Tobago, men will tell you, Doc, I have to drink this weekend, yes? And if he's going to drink, alcohol I mean, and weekends start Thursday, Friday, Saturday, Sunday, that's 4 days, he's acculturated to thinking he can't take medicine. So unless some of these things are gotten at in terms of understanding the culture, so that need for the multisectoral research is there. But I keep wondering if we can't have a partnership between companies like Medtronic, the cell phone companies, the pharmaceutical companies, that will get the cell phone numbers of all those folks on those registers and send them messages appropriate to the disease condition, to the length of diagnosis, so that it empowers them with information, reminds them to take their medicines, because treatment adherence is going to obviously delay mortality, but also avoid a lot of the expensive complications like heart attacks, renal failure, amputations, blindness, and strokes. So you've asked me to talk about multisectorality and legislation. I've tried to give a sense of what we do at CARFA, both the traditional public health and much more the public policy and legislation things, which is where I think the frontier is in the next steps against chronic disease. Dr. Lane at another setting said, you know, it took 30 or 40 years to get into this mess. It's going to take time to get out of it. But we can't just keep doing same old, same old. I challenge you the next time you have this meeting, we need legislators, urban planning and transport. We need education, agriculture, finance in the room, not just mostly public health people. Thank you.
Thank you very much, Dr. Hospitalis, for a very insightful and provocative exchange. May I offer the floor to Ms. Rujani, please, for your presentation? Thank you.
Thank you very much. Thank you very much to OAS for convening this wonderful panel, and to my fellow panelists. I'm humbled to be in your company and proud to wear the distinction of lone woman on the panel, so I hope I do justice to that one. You'll have to forgive my voice. I'm trying to shout over it. The excitement of the UN General Assembly last week really took it out of all of us in the NCD community, which is a good thing because it means that NCDs in health were present and very active and vocal around the UN General Assembly. So if I've lost my voice following the UNGA, that's a very good thing. So I'm very happy about that. You'll just have to bear with me. So I'm speaking today on behalf of the NCD Alliance. For those of you who don't know who we are the leading civil society organization advocating around non-communicable diseases. Who are we? We were founded by, there we go. Thank you. We were founded by 4 leading disease federations in 2009 to advocate around the high-level meeting for NCDs that took place in 2011. Since then, we've grown to 7 federations, including NCD risk factors like tobacco, health system strengthening organizations, mental health and neurological disorders, to a network and an alliance of over 2,000 civil society organizations in over 170 countries. So our reach is truly global, and we really do try to unite all areas of this very complex and very diverse NCD civil society space. We do have organizations, and I see some of them present in the room, like the American Cancer Society, like the American Heart Association, who have very distinct focuses. And then our network also includes concerned individuals, which is exactly what we want. People who see the problem, want to do something about it, and need an outlet to do it. So that's what the NCD Alliance really aims to do. So I've been asked here today to speak to 2 different areas of our work. The first relating to the post-2015 development agenda, which is a very hot topic in global advocacy right now. And the second is how this applies to our regional and national advocacy, particularly the Caribbean region. So to start off, just sort of to paint the full picture of the post-2015 advocacy space and why it matters so much, I think there's certain inalienable truths, if you will, to the MDG framework as they related to health and health outcomes. The health-related MDGs really compelled donor resources, global action, and country-level action around a specific set of health issues, mainly infectious diseases, but also maternal and child health. From 2000 to now coming upon 2015, we've seen marked improvements in these health areas and improved health outcomes overall. But of course, from the NCD perspective, there was a huge oversight in developing the MDG framework, and that was the omission of non-communicable diseases and the conditions that today, as we sit here, have overtaken global disease burden trends and global epidemiology to be the leading cause of morbidity and mortality in nearly all countries of the world. And yet we have a development framework that doesn't touch these right now. So looking ahead to the post-2015 development agenda, we need to reconceive how health is portrayed within this global development framework and specifically call attention that will drive action to NCDs and the other global health issues that really impact human development. So as I mentioned, one of the things that the NCD Alliance is doing is really trying to galvanize political action momentum and civil society action momentum around the inclusion of NCDs in the post-2015 framework. This started actually years ago, before post-2015 was such a hot topic, around the Rio Plus 20 Sustainable Development Conference. And I think at first when the Sustainable Development Agenda came about, all of us health people sort of looked at it and said, sustainable development, we have nothing to do with this. This is about the environment. This is about trees. This is about carbon emissions. And that was a learning curve for us in getting involved in the Rio Plus 20 conference and the Sustainable Development Agenda, because again, it was a push to include health, it was an extra push to include NCDs, and it opened our eyes to all of the interlinkages between health and development and to the need to make these explicit in our frameworks and not just sort of implicit and understood like, oh, it will be great when the development goals eventually reach to influencing NCD outcomes. It needs to be front and center. And so we started on this path a few years ago and as part of the sustainable development movement, not separate from the sustainable development movement. So that was a big lesson learned from the NCD community and specifically for the NCD Alliance. Since then, our advocacy at the global level on post-2015 has only grown and is now including all of our network members and really engaging them in the process. I think it serves us well to note that every major input into the post-2015 development agenda thus far has specifically cited out non-communicable diseases as a priority for health and for development. This is tremendous. It means that NCDs have the political momentum and the space in the agenda to really be recognized in the future framework. The Secretary General's high-level panel report cited NCDs as a priority. Most recently was the Open Working Group final report, and this intergovernmental process and the resulting recommended framework of 17 sustainable development goals and 169 targets, including a health goal and 9 health targets, including a standalone target on non-communicable diseases. So with the standalone target on non-communicable diseases, governments have already recommended that going forward, you need to see, and we need to see, a global mortality reduction. So what this says is take this 25 by 25 agreement, elevate it into the post-2015 framework, extrapolate it to the 2030 timeline, and hand governments back the mandate, well, eventually the mandate, to say, this is your priority for development going forward. So this was a big win for NCDs. Looking forward as the next phase of the post-2015 process continues, our priority for the NCD Alliance and for civil society is to keep this momentum going and to ensure that September 2015, when the heads of state meet at the UN General Assembly, to agree the post-2015 framework, they're agreeing to action on non-communicable diseases and to reduce the morbidity and mortality from NCDs and to address the environments that really determine our health outcomes. So that's our action on the post-2015 framework. Within this, I should say, it's not just about us as civil society talking up to the systems. It's about how we talk to each other. And among this, the NCD Alliance, I'm proud to say, has been at the forefront of really talking to other non-NCD related and even non-health related civil society actors to bring them along as we talk about the next phase of health and development. This includes reaching out to a group that now includes over 60 civil society organizations working on health in post-2015. It includes working with some of the leading thinkers on universal health coverage, on transportation and road safety, on education, on agriculture, to really conceive how health fits in these other pieces, but also how we can feed back on those processes and those agendas. So it's not just talking within one particular silo at the global level. So now to move from the post-2015, which is our very big picture civil society advocacy agenda and objective, to how we're taking this and our action to the regional level and the national level, and specifically the Caribbean region, which is the theme of the panel today. The NCD Alliance, through the generous support provided by Medtronic Philanthropy, has developed a program called Strengthening National Health Systems and Supporting NCD Actions. And this is based on the knowledge that we really don't have a lot of knowledge. To know what to do, you have to know what's going on. And to do that, we had to set about landscaping the NCD space at the regional and national level, but from the civil society perspective. What needs to be done, how can we do it, where can we meaningfully influence along the way, and what are the tools that need to get there. So from this program, we developed a toolkit and a benchmarking tool that provides a sense of accountability to all actors and really a sense of guidance as to how we can go forward in the Caribbean region. So our partners in the Healthy Caribbean Coalition implemented this benchmarking tool in order to assess the response in the Caribbean region, the situation rather, for NCDs, and including an assessment of civil society action within the Caribbean region. And there are a few key takeaways that came from this assessment. And the first being that very few countries have national policies on salt and salt regulation and marketing to children, as Dr. Hospitalis just said. So this is a tremendous problem in the region, and one that we know doesn't exist, but for a civil society perspective, we now have on our priority list for things to address. This benchmarking tool also resulted in sort of the knowledge that very few countries have evidence-based guidelines on alcohol regulation and on alcohol. So what can we do to address treating alcohol dependence within the region? And finally, that there's limited budgetary allocation for NCDs at the national level, as well as limited civil society participation within the national ministries of health and within the national governments in terms of influencing these policies to make sure that they are civil society sensitive and patient sensitive and advocate sensitive, so that there's limited participation. So it created basically a short hit list of where we need to be as civil society to move the dial in the region. So from this assessment, the HCC, the Healthy Caribbean Coalition, is now moving forward with a set of targeted advocacy, and that is very much around reducing the incidence of hypertension based on improving salt regulations in part, looking at alcohol policy. How do we amend alcohol policies, working with other ministries beyond health so that we are changing the situation at the national level. And finally, NCDs and national development plans. If all comes to place on the post-2015 framework, this will give countries the mandate to really move on NCDs, but they need to know to ask. And in order to know to ask for NCDs in your national development program, you have to have civil society there to agitate for that ask. And that's one of the things that we are doing, particularly in the Caribbean region, but also these other geographies, is to make sure that countries feel empowered enough to ask for support and assistance and cooperation in addressing NCDs. So with that, that's a very quick whistle-stop tour about what we're doing from the civil society perspective, but I'll turn back over to the panel and welcome your questions going forward. Thank you.
Thank you very much, Ms. Rutani. And your voice didn't seem distorted at all. Congratulations.
Thank you.
Mr. Hogan, the floor is yours, please.
Well, good morning, everyone. Ambassador Parsons, thank you very much. I appreciate the opportunity to be here to represent Medtronic on the panel. Perhaps even more broadly, I appreciate the opportunity to be representing industry on the panel. And I think it's a very, very good sign for the treatment of NCDs that the panel has viewed the benefit of having industry as part of the discussion today, because I think that the ability to partner with industry is going to be crucial for the treatment of NCDs. And so that's actually what I'd like to spend a few minutes talking about, is this ability and the need to be partnering together for the treatment of NCDs. Medtronic, as the world's largest medical technology company, is focused almost exclusively on NCD disorders. That's where our treatments are focused. Now, we have a mission at Medtronic, and the mission is to partner with healthcare professionals to alleviate pain, extend life, and restore health. Now, since we focus almost exclusively on the treatment of NCDs, you could almost really say that the mission of our company is on the treatment of NCDs. So partnership in this type of a forum is crucial to our ongoing success. Now, when we look at partnership, we really see it in really sort of three broad ways. I mean, clearly one area that leading companies like Medtronic and other leading healthcare companies see is on philanthropy. I mean, clearly philanthropy is a major component of our treatment, but clearly, as we all know, philanthropy cannot be the only answer. That's an important component of it, but it cannot be the only answer. The second major component, though, is on creating awareness for people about how to avoid NCDs in the first place. But then if you can't avoid them, and there will always be a certain population that doesn't avoid them, how do you actually get effective treatment and therapy for NCDs that doesn't drive healthcare costs up, but actually drives healthcare costs down? And then, of course, the third component of partnership is on the actual delivery of therapies for patients that actually need them. And it's probably on that area that I'd perhaps want to maybe go a little bit deeper and talk about how do we partner on the delivery aspect of therapy. Because in order to effectively deliver therapy, that's really where the partnership has to be in a way where it actually drives healthcare costs down. You know, people oftentimes think of the delivery of therapies or the purchase of therapies as being a cost. And of course it represents a cost. But what people often don't recognize is the cost of not effectively treating people as well. I mean, you referenced, Ambassador Parsons, this $47 trillion cost to society, to the global society on the treatment of NCDs in the coming 2 decades. What it demonstrates is there's an awful lot of cost already being put to society for NCDs. It's cost of alternative therapies, it's the cost of loss of productivity, it's the cost of people being given alternative things that prevent other people from working in society because they're taking care of someone that has a lifelong problem. So the way that we can really be partnering best together with the overall NCD environment is to be looking at how can we tailor the therapies that companies like Medtronic and other healthcare companies manufacture. How can we partner in ways that actually target those therapies to the individual needs of a particular country, of a particular healthcare environment, of a particular caregiver, a particular hospital? How do we partner in ways that actually drive the cost of healthcare down? Because if the cost of healthcare goes up, that's not an improvement. It's only an improvement if the cost per patient goes down, because that is what will allow us to have greater access and allow more patients ultimately to be treated. So that's the overall message that I would be delivering here today from Medtronic's standpoint, but also from industry's standpoint in general, is that as you're looking at the way to actually address the treatment of NCDs, you have to be doing it in a partnership together with industry, where we partner together and find ways to actually drive the cost of healthcare on a per-patient basis down, because that will drive down the overall cost of healthcare and enable more and more patients to be accessing it. So I'll stop there and I'll open it up for questions as we go on.
Thank you very much, Mr. Hogan, for that very interesting perspective. I think often overlooked, but extremely valuable in terms of delivery. Thank you. Mm-hmm. So, George, it's a pleasure to offer you the floor.
Thank you very much, Ambassador. We have here on the podium 3 Trinidadians, a Barbadian, and 2 Americans, so we cover the whole globe, right? Dr. Gale this morning mentioned he wanted to thank his staff. The Ambassador Ramden said he wanted to thank his staff. And I know the director didn't say that this morning, but I would like to thank the staff of the Pan American Health Organization This book that you see before you, which has the position of the Americas, was really put together by the Pan-American staff, and Silvana Luciani, who had the major role in it, really deserves a round of applause. Well done, Silvana. Now, Dr. Hospitalis asked, are there any ministers here, any people from various sectors here? There are no politicians here, so I'll say like Joan Rivers, now can we talk? Can we talk? And I'm going to talk to you about, all of you move in circles of influence. Every one of you moves in circles of influence. And I want to take you to take away from here some little thing you heard that be useful in your circle of influence, include knowing that pancreatic cancer is not the kiss of death, that Justice Ginsburg is not the only person who survived pancreatic cancer. I learned that this morning. And you ask, why this focus on the Caribbean? It's not that because we are boastful but there are some things that have happened there that may be of some interest to you. The ambassador mentioned this morning one of the embassies of the Caribbean on NCDs. What is often realized that the way the UN conference really took place, because on September 29, 2009, it was the Prime Minister of Trinidad and Tobago who called actually for a UN conference. So it was Trinidad and Tobago's Prime Minister who actually said we must have a UN conference. We have to give him a lot of credit for that. Now you heard yesterday from the Secretary of Health saying how the Caribbean leadership in this is important. So we want to leave you some of the examples from the Caribbean that might be of use to you in your circles of influence. You've heard a lot about the economics of it. You've heard a lot about the social dimensions of it. There's one factoid. Someone mentioned that obesity is going up in Trinidad and Tobago, and how at Carnival it is how shall I put it? He mentioned, I won't go over what he mentioned this morning, but there's one thing is in Caribbean that is quite remarkable. Obesity in men is rising faster than in women. I don't know why. And no one can explain to me. There's a facile explanation which I won't give to you, but it is a conundrum why obesity is rising faster in men than women, but I won't go into that. But what aspect of the Caribbean experience might be useful to you? So first is the political aspect of it, that you can move politicians. Politicians can be moved by data. And please not to be too disconcerted that your first attempt to move politicians doesn't succeed. They can be moved by data. And one of the examples in the Caribbean that is persistent, why it is this persistent interest, is that every year the Caribbean heads of government talk about NCDs and what they should and what they should do. Every year, the Prime Minister on St. Kitts and Nevis presents to them what you guys are doing and what you should be doing. And it's always based on what are the data available. The other thing that you can do, the Caribbean has been very, I think, successful in having its ambassadors before the UN in New York come together and articulate a common position before the UN. That is something that you can influence. You can influence your ambassadors to be sensitive to and sensible about the problem of NCDs and articulate certain positions before the UN. The other thing that can be done is we mentioned for awareness. This morning, you met, I think it was the director mentioned Caribbean Wellness Day, or James mentioned Caribbean Wellness Day. This is something of the people, a day of the people. And this is something that can be, it doesn't have to be organized by a prime minister, as it were. It can be organized from the people. So possibilities of citizen involvement in wellness activities is something that we all can participate in. James mentioned the aspect of civil society. I want to touch on that briefly, because I think most of us here, most of you here, come from civil society. And what is the role of civil society. One is obviously awareness. We can speak in the fora in which we move, we can speak about NCDs. Many of us belong to churches, many of us belong to clubs, many of us belong to all the other organizations. And I think it is part of our responsibility as part of civil society to get the data to speak in our circles of influence about the problem. And this is one of the things that happens. It doesn't happen as much as it should in the Caribbean, but it does happen that in the circles in which the ordinary citizens move, they can speak of the non-communicable diseases. When I talk about the collaboration with civil society, I'm not talking about collaboration within the government, between various ministries. James elaborated on that. I really like to talk a little bit about the collaboration between the civil society, government, and the private sector. I'm so pleased to see the private sector so well represented. You mentioned frequently part of the private sector. We have champions of the private sector here like Jake McGill and Trevor Gunn and many others. One of the things I think you can do is dispel a lot of the myths about the role of the private sector in disease control. There are a lot of myths that the private sector I used that expression before, all wear horns, they shouldn't be trusted, you can't help them, they only do terrible things to people's health. I would hope that the private sector, you can, in your circles, can dispel some of those myths about the private sector. As you point out, the role of the private, the problem of NCDs cannot be solved without involvement of the private sector. You can take that as a given, as the 11th commandment. The goal of the private sector, NCDs cannot be solved without the involvement of the private sector. And relationship between the private sector and government, we've heard a lot about that, the private sector, public sector partnerships. We heard a lot about the other aspects of the private sector. But one group that I always involve, including the private sector, is academia. I always like to think of academia being part of that private sector, not the government, not the business, although some people say universities are a business, that's another issue. But the academia being another part of the private sector. And I think the relationship between all those parts of the private sector, faith-based organizations, academia, et cetera, can be major advocates for the issue of NCDs. But there's one aspect of it I want to bring up again, the aspect of accountability. It is the civil society that has the major role in ensuring accountability. When our politicians go in these various fora and they make their commitments and they come back home, it is for civil society to be able to make them accountable. And James mentioned the chart. I'm going to show you this chart. Is a grid that is produced in the Caribbean every year, and it can be done anywhere. And what they do is to look at the commitments that were made in the Port of Spain Declaration and see which ones of them have been accomplished this year. You can go to the media and say, your politicians say, you promised this, it hasn't been done. What has happened about it? So I think the issue of accountability, the Secretary General of the United Nations said, this is the goal. We are the dawn of the age of accountability. I don't know how many are old enough to remember the dawn of the age of Aquarius. Nobody remembers that. You're too young. But the Secretary General talked the dawn of the age of accountability, and he's right. That more and more we are seeing that it is the private citizens that have to hold the policymakers accountable, and you need data for that. They have to hold the politicians accountable, they have to hold the private sector accountable, they have to hold themselves accountable as well. These are things that you can do in your circles of influence. And now, Ambassador, as my first last is this. Why the OAS? And we've talked about this, why the OAS and why you've been invited here, why the OAS? The chart of the OAS is a fantastic document, and it talks about peace and justice and how you elimination of poverty, etc. And the OS, the members of the council, in their wisdom, created an Inter-American Council for Integral Development, CD, and you are chair of CD. And one of the things in CD says it should promote human development. And the thesis that we will advocate is this: you cannot have human development, you cannot talk about human development except you talk about health. And you cannot talk about health unless you talk about the major things that are inimical to health. So for that reason, I think your CD has to have more than a peripheral interest in the whole issue of NCDs. That is why I welcome the suggestion by the Director Pajo this morning that the OS is in a key position to help to generate an inter-American action against OECDs, and anything we can do to help in that movement, we'll be happy to do. So we are not politicians here, but as I said before, we all have our circles of influence, and I want you to take away from this the idea that individuals can do something. There's evidence of things that have happened. And the only way we speak about the Caribbean is to show that some of the things that have happened there can happen. But if you can make it there, you can make it anywhere. You know where that came from. That is the message I want you to take away from this. Thank you.
Thank you very much, Sir George Alain. Ladies and gentlemen, I thought we have had some very, very fruitful discussions with this panel. I know we're a bit time crunch, but I would surely like to give you the opportunity to ask a few questions. You have a very esteemed panel assembled before you. Opportunities are rare, like this one. So please make use of the mic. We will entertain between 2 and 3 questions. Then we will proceed to the next panel. Questions, please. You can come to the front. There's a microphone in the center aisle between the 2 sections. Please approach the microphone. State your name, state where you're from, and if you have the question to be directed at a specific person, identify that person, please. Sir, the floor is yours. Good morning.
Yes, good morning. This is William Checkley from Johns Hopkins University. One of the things I heard in the panelists is talk about data, and I wanted to ask specifically about that. In terms of gathering information and setting up surveillance systems at the level of Latin America, especially as you're trying to determine how interventions are being implemented and see if Latin America as a whole is meeting voluntary targets. How do you foresee kind of the involvement of kind of all these multinational collaborations, whether it's country level, industry, academia, become involved and help develop those metrics to look at how we are tackling non-communicable chronic diseases?
Much. Let's take 3 questions and then we'll allow the panel to respond, please. Ma'am, the floor is yours.
Hi, my name is Renee Campbell. I'm a 4th-year medical student at Howard University. I low-key have 2 questions, but I guess I'll just ask one. Sure. So one of the questions I'm wondering about in regards to non-communicable diseases is in terms of cancer, and which cancers are actually in the rise in the Caribbean. My family is Jamaican. I'm first-generation Jamaican. And I was wondering if those cancers have anything to do with obesity or food consumption. One of my last memories of when I was in the last time I visited Jamaica was in 2004. There's this huge long line for KFC, and I remember being very perplexed because I was like, but you have jerk chicken and jerk pork on the road, but why are people in line for KFC? It just didn't make sense to me. And I was also wondering, with just the westernization of developed nations, are there a shift from using cane sugar? Because I just remember soda and drinks tasting much different in Jamaica, much fresher because there was cane sugar. And is there a more influence of high fructose corn syrup, which has been shown to be related to the metabolic syndrome and skipping steps and glycolysis? And are those that westernization, are there possibly additives in that food that's related to the higher incidence of cancers? Because I know in Jamaica, I read the Gleaner, it's 20% of the non-communicable deaths. So that's my question.
Thank you very much, ma'am. Sir?
Hi, my name is Jeff Meir. I'm with the Public Health Institute. And my question is really, I think, for Mr. Hogan, principally, but the other panelists are more than welcome to answer. The NCD world, sadly, is siloed, just like every other aspect of healthcare. And I agree that there is a huge need to include the corporate expertise that exists on NCD treatment and care. But how do we break down the silos between the academic world and the policy world and the public health world and the world of, the Medtronic Corporation, which is, a very powerful entity, but it may not have the same expertise available to it internally that those other two, the public health world and the academic world, have. Thank you very much.
Thank you very much for the questions. There are 3 questions on the floor. Anybody wishes to take Dr. Frederick?
Since I have to leave,
Sure.
I'll answer, and therefore I can avoid the rebuttal. I won't answer my medical students' question, so no one will feel I planted that question. I thought it was an excellent question. So that's the only question I'll skip over. But I think to tie the first question and the last question, one of the things about this conference, and I have to applaud again the ambassador and his counterparts for putting this together, is that we have to bring these collaborations together as often as possible. I know that we have had a significant discussion about the fact that the multi-sectoral nature of this needs to be in the room. But again, that's why we have our medical students here, because this is the type of discussion that we want them to hear about and participate. The way we educate, and if you look at the curriculum of medicine, it is not broad enough, in my opinion, to involve the business of medicine, which will help people understand companies such as Medtronic. It's not broad enough for us to discuss all the social determinants of health in a very involved and purposeful way. So all of these other activities that the students get to participate in give them that broader perspective. And then along the lines of how do we get the data, I think, again, it's a ripe opportunity for us to look at that very factor in terms of how do we get academics to participate in getting that data. And that's a big interest of Howard University. How can we get into the Caribbean and get our medical students and other healthcare professionals who have an interest in this in the various countries and in the various opportunities to build that? And like I said, I think we do a very good job right now in Africa. I described the Zambian project, but there's also a Malawi project where we put up a clinical laboratory and we look at HIV testing throughout Malawi to the far reaches. We have couriers who collect the blood and bring it. The database that they have been able to create on those patients is very, very informative. Patients who otherwise would not have been touched. And those are things in the Caribbean around the non-communicable diseases that we certainly would have a major interest as an academic institution in partnering with industry to build that kind of database so that it's very formidable, as well as we can then feed back into what the plans are to impact those. So again, I thank you for the opportunity to be here today. And as a university, you're hearing it from the top. We are here to partner. If there's anyone who's interested in having Howard involved, we're here. My dean is here and my medical students are here. So after the panel, they certainly will be available. And you can see how forthright they are, so they'll be more than happy to take your questions as well. Thank you.
Thank you very much, Dr. Fredericks. Please, Dr. Fredericks is leaving, so a round of applause for him as a panelist, please. And again, thank you for reiterating your support and commitment to this cause, Dr. Fredericks, and all the best to you, your staff, your students. And thank you for the medical booth outside. Thank you. So again, panelists, there are 3 questions on the floor. Anybody wishes to Mr. Hogan, I know there was one directed at you.
Sure, yeah, I can respond to that question. You know, I love that question for a number of reasons. And the reason I love it is because I think it really sort of is asking the question, how do you reduce, or how do you bridge the rhetoric of the need to do things on a broad scale with the actuality of actually saving a patient's life at the ground level, right? And how do you bring these two things together? But my answer to that is, first of all, that you have to have both. I mean, you have to have the broad policy decisions that create an environment by which you get governments and institutions and large bodies working in the same direction. So you have to have that. But then you have to start from the other side as well. And as the old Chinese proverb says, journey of 1,000 miles begins with a single step. And I think that the way you actually do that is by looking at the individual barriers that are preventing individual people from getting treated for individual disorders. And you have to do that on not only a countrywide, but really almost on a citywide, or maybe even on a hospital-wide basis, because the barriers that prevent access for various NCDs, but every type of healthcare issue for that matter, the barriers to access are so local. And they're different by healthcare provider, and they're different by city, and they're different by socioeconomic levels. You have to go at them on an individual by individual basis. And so, I mean, we try to do that by dividing out our business into broad categories. We have our business unit of diabetes. We have our business unit that focuses on cardiovascular disorders. They work completely as standalone entities, trying to figure out how do we actually generate greater awareness, greater treatment, greater access for patients that are suffering from type 1 or type 2 diabetes. They are not consumed with how the people on the cardiovascular side are trying to solve their problem. They're trying to do it individually, because you have to break it down to an individual one-on-one case. I'll try not to take too much time here, but I'll give an example of one of those things. One of the problems that you have is when someone is experiencing a heart attack, as long as that person can get to a hospital within about a 2-hour window and actually be treated, have their arteries opened back up again, they can pretty much survive completely from the heart attack. They won't have any long-standing debilitation from it. But the critical factor is to be diagnosed as having a heart attack within that 2-hour window and getting to some place that'll enable you to treat you within that 2-hour window. Well, that is a big problem in a lot of the developing world, certainly in Latin America, where people show up at an emergency room, but there is no trained cardiologist there to actually diagnose that the person's having a heart attack, not just indigestion. And there's no way to really get them to the point of being treated. So one of the things that we're doing in a number of our centers around Latin America is identifying a center that has the capability of treating a heart attack, and then going around to all the referral emergency rooms and referral clinics that refer to that center and putting in place EKG machines at those clinics, connecting them with telemedicine so that if a patient shows up at that emergency room saying he's got some problem that he doesn't know what it is, the people there are trained to put the EKG monitors on. It'll be sent via telemedicine to a trained cardiologist that will tell them, yes, this patient's having a heart attack. You now have 90 minutes left to get them to a center where they can actually be treated for that heart attack and have their life be saved ultimately. That's just a single point of reference of an obstacle for saving a patient like that with cardiovascular disease. But you can't do that on a broad global level. You got to do it on an individual emergency room by emergency room level. And that's ultimately the way that companies like Medtronic or other healthcare companies can break down these silos as you talk them between the different therapy problems, the different obstacles, and treat it. You've got to do it on literally a hospital by hospital basis, and there's no other solution to it. But you need these sorts of conferences to be able to get the overall market moving in the right direction.
Thank you very much, Mr. Hogan. Ladies and gentlemen, we have had a very, very interesting discourse from academia, from a regional institution, thank you, Dr. Hospitalis, from civil society, from private sector, and we had a very good wrap-up, an overview with recommendations from Sir George Arlene. This follows a very interesting conversation this morning with 5 ministers of health from across the hemisphere who gave their country perspectives. So I want to say thank you very much to the panel for productive engagement. Thank you for listening. Thank you for your interest. And we look forward to the final panel of the day. Thank you very much. A round of applause, please. Thank you.
Just till tomorrow. So are you at the trilateral?
Ladies and gentlemen, we realize the time for talk is small, and we'll revert to that right after this panel. It's all about partnerships. You can't talk partnerships if you can't talk. And happy that everyone is talking. So, well, ladies and gentlemen, let me start by thanking our hosts here, the Organization of American States, to be able to open up this hall of greatness to everyone that actually legitimately would like to be here is really a great feat. And even those colleagues that by video conference are now joining us from Latin America and Canada, elsewhere in the United States, students at universities that couldn't put aside their coursework to actually come here to Washington. It is a great testimony to the openness and the forward-looking nature of the Organization of American States. And certainly to our partner, Dr. Parson, where the concept of this started at over a small cup of coffee. A great salute goes out to Trinidad and Tobago as well. This panel is the final panel of a healthy lunch. Okay? And let me just quickly start by saying, of course, everybody realizes the end of the day, we want to quickly go back to our colleagues in the audience, but we want to first individuals who are on this panel, which is going to have a broader hemispheric focus. I'll be going of them, and then right after that, turning it over to the audience so we make it very interactive. So don't save. Let me start on my right, Rodney Ghali, who's with the Director General of the Center for Chronic Disease Prevention, the Public Health Agency of Canada. He's also the director of something called the Propel Center for Population Health Impact, University of Waterloo. He spent 10 years at Health Canada, which I think everybody understands what that is, as senior advisor to many senior officials in that context. Directly to his right, Holly Wong, Principal Deputy Assistant Secretary for the U.S. Health and Human Services. Known Holly for a great many years. She's spent 3 years at the Inter-American Development Bank, spent years in the private sector, has worked in 40 countries, and it's great to welcome you, Holly, to this panel. Directly to the right, and Sally's been introduced in so many ways by so many different people, given her equities in Trinidad and Tobago as our former U.S. ambassador. I don't know that I need to really introduce her, but that's my duty nonetheless. Sally is obviously Senior Vice President, heading up the American Cancer Society's efforts globally when it comes to prevention, detection, and treatment of the scourge of cancer and cancer-related diseases. Thank you very much for your continued efforts, Sally. And then Jeff Sturcio, a partner who I've known for a great many years. Today, the CEO of an organization called Rabin Martin in New York City. He used to be the head of the Global Health Council. He used to be the head of the global philanthropy efforts at Merck. Has countless efforts in many different countries. I got to know him best in Africa, and so it's great to welcome you, Jeff, an eloquent spokesperson. Then Mariana Irabarne, she's actually come in from Buenos Aires. She's the head of GE Healthcare's policy efforts within Latin America. But equally so, she used to be at Intel. You've served previously at the Australian Embassy in Buenos Aires, but equally so the EU mission in Buenos Aires. Have a very broad background, and we want to welcome you here. And thanks for coming all the way up from Buenos Aires. If that's okay with everybody, I'm going to start right into questions. I mean, everybody today has spoken about how NCDs are different, how it requires a different societal response than most other disease states, which often can be put in a box. We understand, thus, that we have to be out of the box. And we understand that, that globally, that's the challenge that that all elements of society that are represented here and represented in the audience are faced with. So it means new dialogues. It means new types of partnerships. So that's what the world is calling, and your taxpayers up in Canada are calling upon you. How does your center actually measure up, Rodney?
Great, thanks, Trevor. So I'd like to start back in 2010 when all health ministers in Canada signed on to what we call the Declaration on Prevention and Promotion. And what that did was, as a landmark document for Canada, was sort of set out a few central tenets. And these are tenets that internationally we are all talking about today. It's working across sectors to affect real change. That was the starting point for us to look beyond sort of our health borders, look beyond our government borders to say that the real solutions lie in working collectively together. And so what that has meant for us is the manifestation of what I would say incredibly dynamic and exciting partnerships that we are talking about today sort of in the theoretical, that in Canada we are putting on the ground in reality. We've got 20 or so real multi-sectoral partnerships with non-traditional players that I would say that, even 5 years ago, we would not be having that dialogue with a few of these folks. And these are partners in the banking sector, the insurance sector, sports and entertainment, retailers. And these are folks that, I think one would say in previous times, you would never contemplate working with them in a public health setting. And I think, when I reflect on some of the comments in our previous panel from James or Sir George, the sphere of influence and the real ability to affect change is here. If I can provide a couple of concrete examples of how we are operationalizing the real impact that we're all searching for right now. And so, partnerships are great, but what that really means is, you need to start looking at these innovative ideas for these real solutions. And, we live in a complex society right now. And, in Canada, we've been working on, true sort of health promotion sort of principles for the last 40 years. And a lot of that has been based in sort of the government raising awareness. And, while I think you could argue that worked back in the 70s and 80s, we're living in a really complex society now. And so what that means is that our traditional approaches are no longer as effective as they need to be right now. And so what we need through these multi-sectoral partnerships is leveraging the assets and the expertise of these partners and applying them within a public health context. And so for us, a real tangible example is about 1.5 years, 2 years ago, we partnered with a major sort of marketer within Canada called Air Miles, and they offer loyalty points. And these are points that you would get sort of by going to a grocery store, sort of a retailer, that helps sort of drive some of your purchasing habits. And we thought, what if you apply some of those same principles within a public health context to drive real positive, healthy behavior change? And so what we did was partner with this firm and YMCA of Canada to see if we could get people more physically active by offering them incentive points. And so while we had originally targeted around 20,000 Canadians to be part of this pilot project, what we found was an overwhelming sort of interest in this. We are now managing well over 55,000 Canadians across 15 YMCAs across Canada. And what we have is a real tangible behavior change that we are now demonstrating. And so we started with a baseline of 1.3 visits to the gym per week. Through this incentive program, we're now seeing that well over double. So we now have a rate of 2.8 visits per week at YMCAs that are participating in this program. And so what that's demonstrating is this is real behavior change. So this is moving beyond sort of simple awareness raising to demonstrable change. And what this is also sort of demonstrating is true sort of value for dollar, both for the government, which is investing taxpayer dollars in these programs, as well as a demonstration of how you can take these principles that are being applied in other sectors and show the power of these partnerships in real results.
Thanks, Rodney. All these great, fantastic things happening just up north. Well, south of the border again, Holly, you very senior official at Health and Human Services. As people look back at non-communicable disease, they often look back to the United States. So it'd be lovely to have your broader perspective on what the U.S. is doing globally to aid beyond its borders, but certainly feel free to comment on things that we may be doing within our borders that have some lessons for the rest of the world.
Thanks, Trevor. So thanks very much to everyone for inviting me to be on the panel today. So Rodney stepped back a few years. I'd like to step back to 2011 when the UN held its high-level meeting on non-communicable diseases. And in fact, it was just before that meeting took place that I joined the administration and was thrown immediately into working on that high-level meeting, which was a huge priority not only for the Department of Health and Human Services, but for the Obama administration overall. I think kind of leading into that meeting and since then, much of the focus of my department and our Office of Global Affairs in particular has been looking at and tracking all of the work that's been happening on non-communicable diseases. We are working on that on a multilateral front, working very closely with the World Health Organization. My staff and our team and the other parts of the US government as well have been working on many of those discussions, including working on the targets, the coordination mechanism, and tracking progress that can be made. Much of the work that we are doing on a bilateral basis as well. So not just with the World Health Organization, but much of the cooperative work that we do with other countries. Many of those efforts are with our Centers for Disease Control and our National Institutes for Health, and some of the research work, some of the programmatic work that happens. But let me turn a little bit to kind of what we're doing here in the United States on NCDs and how that is a priority and some of the work that we're doing. And I think one of the keys there, and Rodney spoke a little bit to this, and it's a theme that we've all talked a lot about as we've worked on NCDs for many years, which is that this is a multi-sectoral issue. It can't be done by the health sector alone or by the government itself. And that certainly remains true. I will say, however, with some degree of maybe frustration, is that we all say that it's multi-sectoral, and we truly believe that, but making it work on a multi-sectoral basis is really, really hard. The number of meetings that I go to, that all of you go to, and I would bet that 95% of the people in this room work in the health sector or work on health sector issues primarily. Getting our colleagues from other departments and other agencies to come to these meetings to work with on these things, it certainly happens, but not as much as we would like that to be. I was at a meeting last week which was on a slightly different issue. It was on global health security, but it was the same theme of having to work across a number of sectors. There were 22 ministers from around the world in that room. 20 of them were from the health sector. So, getting our colleagues from agriculture, from education, from transportation to join us in this effort, I mean, on some level that commitment is there, but making it turn into practice is a little bit harder. Not to say that we don't have successes. I mean, we know that in many countries, not just in the United States certainly, but in many countries there have been efforts to bring agriculture into these discussions, to have farmers markets, to have closed off streets and bike lanes and different city planning efforts. So those things do happen, but I think one thing that we would really like to see happen much more is true participation from other sectors, whether it's across the aisle or whatever it takes to not have health ministers and health departments try to struggle with this issue on our own.
Perfect. Thank you very much, Holly. Sally, we've been on panels together. I've heard you frequently speaking in other venues. You frequently speak about a term that I think globally is understood called PPP, private-public partnership. But for some reason, you add another P on the end of that. So quadruple P. So I'd like to understand better what you mean by that in your personal interpretation and what it means for the fight against NCDs.
Well, thanks very much, Trevor, and I want to thank Ambassador Parsan especially for his initiative with Medtronic and opening this forum, because I think it already does reflect we're a little bit broader than just the health sector. After all, we brought in the diplomatic community, and of course, as a former diplomat myself, I like to think that that's an important one to bring into the picture. And I know now in the U.S. government, was not the case in my day, but now all U.S. ambassadors are sort of put through a boot camp on public health and taught that part of of their diplomacy is really reaching out to other governments and really to civil society. And of course, that's what I mean by the 4 Ps. It's not just that I stutter so that I can't say P, 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 P. I have to say P, 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 P. It's that I think it's beyond public-private partnerships. I think it has to be public-private patient partnerships. And I think the patients or the people are what maybe has been missing. They are, of course, a part of civil society, but I think we see, particularly with young people, and I'm thinking about the Young Professionals Chronic Disease Network, and they're here today, and others. Yes, they're loosely organized into civil society, but they're also as individual tweeters and Twitterers and on Facebook going out beyond even the confines of what we used to think of as a civil society organization like, let's say, the American Cancer Society. I mean, in existence for over 100 years, well-formed, plays a role in sort of civil society. But I think we need to we know people are empowered, and they're empowered to use their voices, and they're empowered to use their voices to really begin to make a difference in this epidemic. And I think that's the key to the change that I see. And certainly in the world's experience on HIV and AIDS and how we tackled HIV and AIDS. And I think without the activists in the room, we never would have gotten to the point where everybody in the world knew something about HIV and AIDS and thought it was important to fight it. That affected governments, it affected the private sector. I mean, suddenly through this kind of political activism, if you will, the financial coffers were opened, and that in turn has led the way to really some important breakthroughs on treatment and on new products. I think that what we saw in AIDS it started really from the bottom up, and the activists really got a hold of it, and they created change in their own communities, and then they got to the sort of divide where I can remember very well as part of the founding generation of UNAIDS, and we had every 2 years there's a big AIDS conference, and the AIDS conference in 1998, which was actually held in Vancouver, brought the exciting news about there were antiretrovirals out there. Dr. David Ho had discovered how you could keep the HIV virus sort of at bay in a person, because before that, of course, it was just a fatal disease, and now it's become a chronic disease. But in 1998, great optimism. Oh, these treatments are there. Then the next AIDS conference, which was in 2000 in Geneva, huge pessimism as we sort of realized that there was an equity divide here, and that what was going to be life-saving in the first world was going to continue to be a fatal disease in the places in the world where it was striking harder. So I think, and then, then this tremendous activism led to people saying, no, it is a matter of equity. Where you live should not determine if you live. And I think a huge push put forward by many companies, many governments, by the UN system, the WHO, PAHO in this region, to say, we can't just fold our arms and say, oh, well, it'll be all right for the first world to go on with its life and we'll put AIDS in the past, but we'll just see this epidemic, wipe out whole populations and certainly economies. No, we've got to do something, certainly on the prevention side, but also on the treatment side. And I think now this new tsunami, if you will, of non-communicable diseases, if we're going to be successful at fighting it, we're going to have to really have everybody theoretically at least stand up and say, I am HIV, as Nelson Mandela and others stood up and said, I am HIV positive. Now we have to have people stand up and say, I'm NCD positive. I care about this. I'm affected by it. It affects my life, my family, my community, my nation, and the world, and I'm going to do something about it. So when I talk about the 4 Ps, it's to say, let's really get this, not just talked about at the UN and other high-level forum and among ministers of health and hopefully other ministers and among ambassadors, but let's see what we can do about pushing this from the grassroots to the grass tops.
Yep, perfect, Sally. Thanks.
Thank you.
Thanks for explaining. Jeff, you've been around the, around the horn a few times, and I would even you're probably one of the more published authors on this particular topic, this emerging topic. And it obviously, so a lot of people are going to be putting some weight in your words in answer to this question, which is, depending on where you are in society, be it an academic institution, be it a government, partnerships, what are what you've seen to be sort of the universal elements of success that we might be thinking about, or words of inspiration to get us to more change? Rodney, you mentioned that. I think it's very important. Others have mentioned that word as well. So please, Jeff.
Sure. Well, thanks, Trevor. And I also want to thank Ambassador Parson and OAS for sponsoring this session. And I'm pleased to have an opportunity to share a few ideas with you. One of the things I want to say before I answer the question explicitly is that I'm actually quite optimistic about where we are in dealing with the challenge of NCDs. Sir George reminded us earlier that it's been almost exactly 5 years since the Prime Minister of Trinidad and Tobago called for this issue to be put on the international agenda. And we've heard about the NCD high-level meeting in 2011, and we've spent the entire morning hearing about all the really important work that's going on at different levels throughout the region. And that's replicated around the world. You're seeing that in Asia, you're seeing that in Africa, as well as in Western Europe and Eastern Europe. So there's cause for some optimism. And one of the things that we've learned also, which is another reason that I'm optimistic that we're going to continue to make progress against these challenges, is that in the discussions around the post-2015 agenda, there's a consensus that universal health coverage should be an important part of that agenda, so that the political and diplomatic classes will continue to focus on these issues. But also at the same time, we've learned that ensuring that we address NCDs effectively doesn't necessarily require more or better resources, and that we can actually achieve a lot by just doing a more effective job of implementing what we already know. So with that thought in mind, and also keeping in mind what we've heard of many of the examples in countries like Honduras and Mexico and Trinidad and Tobago, San Lucia, Paraguay, the other countries we've heard from today, let me just offer 4 specific success factors to respond directly to Trevor's question. The first is that we have to make a major investment in prevention. After all, by preventing future NCDs from developing, it's a way of dealing with the major impact, the major economic impact of NCDs. And so we know through work that's been done by the WHO and others that there are certain best buys, that we can deal with tobacco use by taxing it and encouraging people to understand exactly what risk they're putting themselves at by smoking. There are ways to facilitate smoke-free workplaces, to increase health promotion campaigns, to reduce the consumption of salt, fat, sugar, and trans fats in foods, encourage more physical activity, et cetera. We've heard all through the day of examples of how these risk factors are being addressed. And by really making a major push on prevention, and this is something that can be done not just through government action, but through our everyday experiences, since a lot of NCD risk is behavioral, and we can actually change our behaviors and use social networks in that way to change them. In fact, it's interesting that one of the few things that's contagious about NCDs are the behaviors that lead people to develop NCDs.
young people who begin smoking because their friends urge them to smoke, people who start eating unhealthy foods simply because, again, their friends or their parents take them to fast food outlets rather than eating things that we know are healthier. And so working with social networks, real social networks, not the virtual social networks we usually talk about, is an important way to ensure that prevention will actually work. The second point that I want to say is that we should also ensure that primary care is reconfigured in a way that will actually integrate the treatment and prevention, treatment, and care of NCDs into the health systems that already exist. And so this is one way in which the health sector has a role to play in assuring that we can do a better job. But because primary care is closest to the community, we can also take advantage of community networks in working with primary care clinics and other institutions to ensure that we expand health-seeking behaviors, that NCDs are tested for and diagnosed sooner, that interventions are made before people get very ill and require surgery or dialysis and some of the other things that you've heard about today. So primary care is really an important locus for strengthening the response to NCDs. The third is one that Sally was just speaking about and that many others have talked about today, and that is multi-sectoral partnerships. And the point here I want to make is that I think multi-sectoral partnerships need to be a new way of working to address NCDs, that it shouldn't just be something unusual in the way in which the health sector and others respond, but it should be the usual way that we operate, because it's only by bringing together complementary resources, complementary skills, and complementary perspectives that we'll actually be able to find the innovative ways to address these conditions. And those partnerships depend not just on the health sector alone. As James Hospitalis made the point very eloquently, we really need to think about what other sectors in government, other sectors in society can bring to addressing NCDs. That's particularly important because non-communicable diseases are a set of conditions that really relate directly to social determinants of health as well. Where people live and work is often an important factor in determining how these risk factors will actually lead to disease conditions, and also ways in which people learn and play can have an important impact on whether they stay healthy or not. And then the final point I want to make, and this reinforces in a different way the point Sally was just making about PPPs, I want to just focus on the importance of the other P in public-private partnership, people partnerships, that is the private sector. Now, we've heard a number of examples, really interesting examples today, of the way in which companies like Medtronic and GE and others in the private sector are engaged in the fight against NCDs. But I think it's important for us all to think about ways to generalize those potential partnerships and think about ways in which companies, not just in the health sector, but companies all over the economy, can help to improve the health workforce. They can adopt smoke-free workplaces. That's probably the one thing that would have more impact than anything else on helping to address NCDs across the region. They can create healthier product offerings. A good example here Mariana made me think of this in Argentina. There's been an effort, cross-sectoral effort called Menos Sal, Más Vida, to bring something like 25 major food and beverage companies into the effort to redesign their products so that they're actually healthier for people. Private sector in many industries can help with reaching the underserved by using what they know about supply chain management and logistics to do a better job of getting innovations to the people who need them. And then finally, in a more general sense, you could even think about how the private sector can help to build healthier cities, since the region is becoming more and more urban over time. And that gets into questions about designing pedestrian-friendly streets, building healthier buildings, dealing with issues like pollution. And obviously that runs way beyond just the confines of the health sector. So those are four ways in which I think that we can use prevention, not forget the role of communities in primary care, the significance of multi-sectoral partnerships, and using all of the skills and resources in the private sector to come up with solutions that will help us to really achieve the goal of a more equitable, a more efficient approach to these issues, and also one that will lead to solutions that will bring health for all over the coming years.
Thanks, Jeff, very much. So a great segue actually to Mariana, and Mariana, just let me remind you that you're carrying the weight of Latin America on your shoulders on this panel, right? As you think about the answer to this question, certainly there's a lot of discussion about the healthcare industry's interests in non-communicable disease. It's a legitimate discussion. There's certainly, the perception on the outside that healthcare companies might have a vested interest in the outcome from some of these discussions on non-communicable disease. Can you kind of set us straight? Is that rumor? Is there truth? And can you let us know sort of the GE perspective on all of that?
Well, maybe I should let you answer that one. But I think it is a valid question, but basically we have an interest in this, but it's not for the reasons that one might think, and I think it has to do with the fact that if we don't find a solution for NCDs, the health systems in the region and in the world will not be sustainable. And so there won't be any human resources available or possible infrastructure, and we wouldn't be able to invest, wouldn't have the resources to invest to solve this problem. So we really need to tackle and focus on prevention. We heard a lot of statistics this morning about the impact of NCDs, and I think that sometimes it's important to bring those numbers to be able to visualize them a little bit more. I think that probably everybody in this room has somebody in their family or a close friend who has been affected by NCDs, and that is the size of this problem that we have. It is personal for all of us, and I think that it is incredible that this is not at the forefront and that it is an emerging topic, as was just mentioned a little bit ago. I think that is why it is so important. James mentioned a lot of the possibilities for partnership in the previous panel. We fully agree with those, and what I would like to do is, since we are a healthcare industry, as a healthcare industry companies, we have responsibilities. Part of that social responsibility is philanthropy, but that is obviously not enough. And we need to focus on other issues. I think that we need to focus on the technologies that we develop going forward. We need to listen very closely to the patients. We need to listen very closely to the governments, to the clinicians who are implementing these technologies. We need to make sure that the technologies that we develop are affordable, not just in terms of the cost of the technology when it is acquired, but the implementation, the procedures, that the procedures that the governments and the hospitals are able to maintain these technologies, and also that they are usable. Sometimes, and I've heard this throughout Latin America, you meet ministers and they tell you, we have loads of equipment that our people cannot use in hospitals, and you see this over and over again. I think we have a responsibility to keep training the human resources in these hospitals to use that technology, but also to make sure that the technology is appropriate for the context. So, a super complex anesthesia machine in a rural setting is not the right answer. And technology can help with that. There's software. What we're developing at GE is we're focusing a lot on software that can guide. Sometimes when you don't have a technician available, it can be a rural worker or social worker who can at least use that technology so that through telemetry or through lose for the word here, you can. A doctor can actually do the diagnosis. The other issue where we're focusing very strongly is on early diagnosis. As you know, this is a very important issue. Identifying the disease at an early stage, we've seen this very clearly with, just to give an example, breast cancer, a stage 1 cancer, when it is identified, the possibilities of survivorship are completely different than a stage 4. And so there is no longer an excuse not to invest in early diagnosis. That is an area where we have the responsibility to support governments in the region and worldwide to implement these programs. And I mentioned training and management of the equipment. I think that is something where we have a responsibility to partner and to see how we make use of what is available. And one last thing I would like to mention, I think, has to do with big data. I think that, this morning, Ambassador Pashan mentioned that this NCDs is like a hydra and that it's a bowl of spaghetti. You have a lot of sectors convening on a very, very complex problem, and we need to use data, the data that we have with the health technology machines, but also data that we can get from other industries and bring that data together to analyze it, because that is a key element to find a lot of different correlations on NCDs that we are not seeing right now. The ambassador of Trinidad and Tobago this morning mentioned, he said, well, some years ago, NCDs was what you died of from age. I mean, you have to die of something. And there was no conscience that this was preventable. I think that we really need to go beyond the awareness and get onto the action and access.
Thanks very much, Mariana. In fact, your last comment about data is so important, and there's an organization that's in the room, and I think many of individuals from this organization deserve great thanks for the publication that they put together. Our colleagues from PAHO, Dr. Anselm Hennis, I don't know if you're there, Dr. Hennis, or he's probably already left. Obviously, there's a lot of activity at PAHO today, but I know members of his team are here, and a great publication should be on your seats or should be out in the hallways, and it really is data-driven, but also data for action. And I think it speaks directly to exactly what we're all about, I think on this panel and elsewhere. I want to keep it there, and I want to turn it over to our colleagues in the audience. I realize that there are many others that are listening by webcam. Unfortunately, there's probably not an easy way to get those questions, but for those individuals that may be in the room, we certainly welcome you to approach the microphone if you have any questions. Comments, keep them 15 seconds or less, please. Okay. Two ladies approaching the podium. Are you leaving for healthy lunch, or is it a question? All right, please.
Hi, once again, my name is Renee Campbell. I'm a medical student from Howard University, so I had to write down my questions so I don't lose my train of thought. So I was wondering, as you mentioned the private sector, how do we hold them accountable, like encourage the concept of social responsibility? You mentioned, supply chain, and I also got my MBA. And, I imagine that, globally, since we're, moving to, being more integrated globally, with supply chain and procurement, the whole thing is, minimizing costs. And I feel like, at least in America, I can see this. We outsource food that isn't necessarily healthy from other countries, and those countries might not necessarily have good hygiene or safety protocols in their factories. I remember reading an article in NPR about how now America, we get chickens that are killed in China, then they're killed, they're skinned, they're frozen, they're shipped from China to here, and then they're sold in stores, they're sold in the boneless chickens that you get Tyson or McDonald's, and China's protocols and hygiene in terms of their factories, they had tons of things where feces were found in their sort of infection. So how do we encourage companies, especially in Latin America, to have that social responsibility to not outsource just because it's cheaper to make money?
So it seems like for these two questions, you might be looking in this direction. Okay. Do you want to be more directional?
Sure.
Is there a specific individual? Jeff, it looks like they're looking at each other. So does that sound right?
Question you pose. First of all, as you rightly point out, it's not just where we get chickens from that is now global. Everything is global. Most of the medicines we use in the Americas are probably made in India or China. just because of the widespread use of generic medicines and the global trade in those medicines. So again, James Hospitalis alluded to this in his remarks and said that one of the things we need to do is be conscious of the way in which trade policy and just the way the economy works has an impact on the sorts of products and services that people are buying or have access to. So the first step is just to be conscious of that and to make sure that we take that into account as we plan interventions in dealing with NCDs. Secondly, the best way to ensure that companies are acting responsibly is to have an open dialogue with companies in forums like PAHO has a forum for action on NCDs that has involved the private sector from the beginning. That's one way, and there are also national fora. We heard about in Trinidad and Tobago where they have a partners forum at the cabinet level to encourage dialogue with the private sector. And in those dialogues, I think it's important to move from the theoretical notion of how the private sector can help the public sector and civil society in improving response to NCDs to specific projects where you can actually define what the roles and responsibilities of the partners are. You can set out explicitly what the shared objectives are. You can have shared measurement to ensure that those objectives are being met, and then finally that you have shared accountability so that you have a way of seeing whether you've actually achieved what you hope to do as you set out together on that program. And I think through more and more of those kinds of specific projects to deal with specific issues, you'll find that companies, as well as civil society and the public sector, will find ways to work together with positive outcomes for public health. So I think that's the major way that I think it's important to think about these things, is to get down to specific projects where you can really identify what each of the partners can bring to the party.
Thanks, Jeff. Any other comments from any other panelists that feel moved by the question? Yes, please, Holly.
It's obviously not just a responsibility of the companies in terms of what they do, but there's also regulatory responsibility on the part of countries. And part of what we do is working with other countries and working with multilateral institutions, including WHO and PAHO and the OIE and the FAO, in terms of what international standards have to be for food safety and things of that nature, to make sure that products which are all going across borders are safe for all consumers.
Let me just, as we're going to go to your calling, I hope these are good answers to your questions?
Yes.
Okay. It's great to see so many students and so many medical students involved. I mean, if we're going to change this discussion, it's got to start exactly then. In fact, it should start much earlier, but so very happy to have you here as well. What was your question, ma'am?
Okay, hi, I'm a fourth-year student at Howard University College of Medicine, and my name is Olabola Awashika. And actually 5 years ago, I did an internship at the Pan American Health Org in the Gender, Ethnicity, and Health Unit. And one of the things that we really honed in on was the issue of disparities and just the inability of certain communities to gain access to proper health care or health management, particularly the transgender community and also different ethnicity groups and also gender groups as far as like access of health care for women. So my question would be that, is there a discussion or effort to put forward policies oriented towards the association between factors of gender, sexual orientation, and ethnicity with the rise of non-communicable diseases in the Pan-American
So are there efforts to
diaspora.
connect that?
Sorry?
What efforts are afoot that connect those? Is that?
Yes.
Okay. Thank you very much for the question. Do you want to direct it towards anybody in particular?
It's open to everyone. I
Open
know it's
to
a very
everyone.
complicated
Sally,
question. But
you're leaning forward. Do you feel moved, or do you not feel moved by that? Okay, Rodney, yeah?
I can maybe address that question from a Canadian context and maybe from a governmental sort of context. And I think, this sort of relates to an early comment around data. And so what's really important is to understand what the trends in the data are telling us as policymakers and decision makers around disparities that, any one sort of community may be sort of facing. And so if I look within a Canadian context, I think we see that there's a disproportionate number of individuals within our Aboriginal communities that are affected by overweight, obesity, and various non-communicable diseases. We also see that potentially through new immigrants, that there's also a disproportionate sort of effect. And so what that means is that, as policymakers, and I think, basically colleagues sort of around this room and sort of elsewhere, need to think about that as you contemplate new interventions, new initiatives, that what's clear, I think, in all of the public health efforts that we have deployed is that there's no one size fits all, and that there are certain interventions that you can apply through a population base and others that have to be targeted and tailored towards specific communities that are culturally relevant, culturally sensitive to ensure that the appropriate behavior change can actually be affected through those projects.
Okay. Hopefully that was a good start. Thank you for your question. Thank you very much.
Welcome.
Yes, sir.
Hello, Luis Alejandro Salicrup from the Center for Global Health at the National Cancer Institute that is part of NIH. This is more a comment or observation regarding to this panel and previous one. I heard
Let's keep the observations to about 30 seconds.
Yeah, I heard a lot about technology and, and I think it's important, that any policy has to be evidence-based and research is crucial. I think Sir George and Jim and Sally alluded to that. And I just want to make everyone aware of some of the things that we are working with PAHO, WHO, CDC, and others. We are supporting a stigma research grant, which is crucial for the control of NCDs. We have a project on M-health research. Everybody's talking about cell phones, and so we want to support how that, and we have also a grant on technologies for lower and middle income countries, how to make them portable, that Mariana was talking about that. And we have an HPV testing upscaling project with PAHO, CDC, and others that we involve 7 or 8 companies, and we are working with them and the ministries of health.
Thank you very
much. So I think there's a lot going on.
No, it's an incredible campus, and I've actually spoken at the campus, and it's a great contribution to the American taxpayers. To the global cancer effort. Thank you, sir. And I guess people can approach you directly with any questions about that. Yes, sir. Could you please, maybe I should take my own medicine and remember that this is being interpreted, so I have to slow down. I would ask my questioners to do the same.
Yes. Phil Castle, Global Coalition Against Cervical Cancer. 2 very quick comments. The first one is this notion of vested interests, whether it's private partnership. Everybody in this room has a vested interest, and thank goodness for that. So thank you for being at the table. The second comment is that I don't see that this is going to really move forward until we really address the fundamental aspects of capacity building, training, and education. You cannot walk into any of these countries and say, here it is. First of all, I don't want to do it for them. I want to train them. I want to educate them. I want to give them the technical support. Just like I think many others do. But without that commitment to teaching them to fish, we are not going to get out of the gate. And I'll stop there. Thank you.
Very difficult to disagree with both. Oh, we've got 2 hands already. Sally, you haven't gone first, so and then Holly, please.
Well, thank you. I want to just give a shout out to Dr. Phil Castle, who has really done incredible work on cervical cancer and trying to figure out how we teach people how to fish. But I think it's certainly in the cancer field, one of the, next to tobacco, which Jeff already mentioned, one of the best buys that we have. And we know that in this region alone, we had 83,000 women diagnosed last year with cervical cancer, and 36,000 of them died. And the mortality rates in Latin America and the Caribbean are 3 times higher than they are in North America. So I think cervical cancer is something that we really have established a partnership. It's a really good partnership in Latin America around cervical cancer. It involves our colleagues from NCI and our colleagues from PAHO, and also the cancer institutes from all the Latin American countries are involved, and ACS is involved more on the advocacy and awareness building side of it. So we really can do something about cervical cancer. Think of all the years that I worked in HIV and AIDS, and people were just crying for if we only had a vaccine. And we have a cervical cancer vaccine called an HPV vaccine, and I was very happy to hear this morning that Trinidad is one of the leaders in the region by promoting universal vaccination for girls. I think it's very important to have early screening, but let's not forget that we have a vaccine, and we need to in our country as well, where vaccination rates in the United States are only at about 32%. We really have this life-saving tool in our hands. Let's do what we can to get it out and to save lives that way.
Access,
So,
absolutely. Holly, please.
I agree completely that in order to really address chronic diseases, we have to have good, strong health systems. We have to have well-trained workforces who know how to deal with this. Much of the work that we do with other countries is focused on that. So just two examples. One is that out of our NIH, the National Heart, Lung, and Blood Institute, has a number of international collaborating centers of excellence where they are pairing up institutions in Latin American countries, in particular Argentina, Guatemala, and Peru, working with institutions in the United States and in Canada, I believe, working on capacity building, focused particularly on cardiovascular and pulmonary diseases. So again, it's building that capacity. Another example is our Centers for Disease Control and their field epidemiology training program, where they work with other countries to help develop that capacity. In particular, one of the countries that they've been working with is Colombia. And as part of that FETP program, they have built a module focused specifically on chronic diseases, which is one of the few in the world, in fact, because much of the emphasis of FETP is on infectious diseases. So they're starting to turn that focus to chronic diseases. But I also want to say that in terms of capacity building, I take your point, but we also shouldn't be looking at this as we go out to other countries and help them. In fact, much of the bilateral work that we do on chronic diseases, it's a partnership, and as much as we might be able to help other countries work on some of these issues, there are things that our CDC and our NIH colleagues are learning from other countries and successes they have had. So it's not just a one-way kind of, we're training them how to do this. We're learning from all the other countries as well.
Absolutely. So true. Thank you very much, Holly. So please. And then I think looking at the time and looking at the fact that we've got two more questioners, I think we're going to have you, our Young Professionals Chronic Disease Network colleague in the back as the last question, but please.
Yes, hello. Amy Glover from McClarty Associates. I'd like to hear from the panelists with respect to what engagement has gone on in terms of reaching out to the food processing sector. Obviously, there's an obesity, diabetes problem throughout the region, and I think also creative solutions are required. I know PAHO had worked on a Salt Smart initiative a while back. What else is being done and what should be done to engage with the private sector in the area of food processing? Thank you.
Rodney?
That to start, and so I think it's a really important question, and I think what it highlights is, the issue of looking at the private sector. It's not sort of this great sort of lump of sort of organizations, and that we need to be a little more sophisticated in how we sort of look at the private sector and sort of the interests that they have across sort of all the different areas. So from a food processing standpoint, I think what's really important for governments and for civil society and others is to engage with the sectors that we think that may have sort of an interest that's affecting sort of the trends and, I think the objectives that we're having in a constructive way, and not in a sort of combative or, a non-productive way. And so, I think recognizing that we all have a certain role to play It is engaging with them in a way that can help sort of move the bar through the various tools that we have. And so, we've heard a lot of discussion around, governments can take sort of legislative and regulatory approaches. We can also take a moral suasion approach, which is trying to affect the business behaviors of companies in a way that will sort of, address all of our interests, both from, public health and from an economic standpoint. And I think this kind of gets to some of the comments earlier around, corporate social responsibility and what we sort of view, I think, within the Canadian context. And I would argue, certainly within American context, this, I think, a nod to one of the earlier panelists from Harvard, which is that notion of shared value. And so it's this idea that you can work towards common objectives, even in the face of what you think are conflicting sort of bottom lines. And, we are all members of the same community, irrespective of whether you work in the government, civil society, or private sector. And I think it's through the advancement of that notion of shared value that we can see a re-engineering of different sectors, private, public, not-for-profit, that will eventually get us to the goals that we're looking for. And that's certainly what, from the Canadian perspective, we are trying to accomplish.
Any other comments? All right. Final question.
Great. Thank you. And I have a brief comment as per your allowance, Trevor, to do so. I just wanted to follow up on Ambassador Cowell's comment. She'd mentioned us, the Young Professionals Chronic Disease Network. My name is Jordan Jarvis. I'm the executive director. I'm also a fellow at the Harvard Global Equity Initiative. And so the Young Professionals Chronic Disease Network is a global community, multidisciplinary community with over 2,000 members in different countries. We have an online community that I just wanted to mention to all those in the room and those joining us online that you're welcome to join us at ncdaction.org. And we are also growing our grassroots component at the national level, and hope that you'll come introduce yourself to me if you're interested in joining those from Howard University or online. I'd love to speak with you. Thanks.
And that's right. I mean, chronic disease prevention, at what point in life is it most effective, if not in youth? It's a great organization. So, super. Well, I think we're going to keep it here. I think we're going to go to closing remarks right in front of this healthy lunch, which we planned for you. It's been an incredibly interesting panel. Mariana, maybe I'll start with you. You've obviously commented. We've sort of danced around the issue on conflict of interest. I think certainly you've proven the point on what value is, and certainly all organizations have, to a great degree, as one of the commenters said, vested interests, be it NGO, be it government. All of them have ethos, all of them have these things. Jeff, you've imparted on us the wisdom of the years and the lessons that you've put forward. Sally, you've certainly put P in the center of the discussion as opposed to an add-on at the end of the traditional PPP and been very eloquent on that. Holly, thanks for your continued leadership and that of the HHS family, which you've laid bare here, I think, in terms of not only the U.S. experience, but bringing it overseas. Ron, you've certainly broken down the mold of what some people think about government and some of the partnerships that you all have done. Hope you'll continue to lead in the way that you've done. And with that, I'm going to just thank everyone very much for, I thought, a very interactive as it can be for the amount of people and the technology available to us. Thank you for your time investment in both panels. Mm-hmm.